Doc, I love your sweater.
Thank you. Yeah, it's finally time to bust it out now that it's snowing.
I'm in Cleveland and we have like a foot at least, and it's supposed to keep snowing until midnight.
No, I know it's still going. I can't see out of my basement window, so
Oh,
that's a
I
bad
love that.
sign.
You're from Lancaster, right?
Yeah, yeah,
So glad to know nothing's changed.
exactly. I'm kind of
Still haven't
sad.
gotten an email from Patty.
Yep.
I'm supposed to be driving to Athens tomorrow night. Can't get a COVID test.
No, she's like, oh yeah, just go to CVS, get a rapid test. Okay, the closest CVS that does rapid testing is in Columbus, and
Oh,
I
great.
yeah, and I called them and they don't have any availability until Thursday. So I can't wait for Patty's response. She's just gonna be like, "Oh, I'll just drive to Cincinnati, where it's $75 or whatever the fuck." So we'll see what happens, but
Yeah. No, I emailed Penny and I was like, hey, first of all, I have to drive tomorrow night to go to Athens. So can you please tell me what we need to have before tomorrow night? And she was like, yeah, you just need your laptop. I was like, okay, you couldn't have just said that in the original email. And then I was like, also, I am supposed to work 9 to 5 like every day this week. So I just had to tell my job that I can't work. And I get off tomorrow at 5. So I have no way to get a COVID test before then. And she just goes, I'm including Patty in this email. And I haven't heard anything since. It's been like 3 hours.
no, I think that Patty is telling them like, "Oh, if they say anything, then just CC me or something," because I think that everybody's just diverting them to Patty. Um, yeah, and I tried to even do it through COVID operations, and COVID operations was like, "Oh yeah, we can set you up with a test," and then they called me and they're like, "Yeah, we'll set you up with a test, but it will take 1 to 3 days for the results to arrive because we don't have any availability in rapid testing." So I'm like, whatever. There's just no way it's gonna work. But I don't know if they're able to do anything on finals week. It seems weird that they're trying to force it on Thursday.
I know. Like, I got an email on Monday saying you need a COVID test if you're planning on returning to campus, and I was like, "Oh, I'm not planning on returning to campus, so it's fine." Like, thanks for the notice.
Oh, God bless it. They'll have to figure something out, I guess. Okay, and I'm gonna start at 7. Just kind of waiting for people to filter in. And okay, in case you missed it, so uh, most of my material is from review sessions. I basically go into review sessions and I go, what do I need to know? And then I write down everything that they say. And I take those lists of things they say and I number them out to try to get an idea of what content will be on the exam. And then I make questions based off of that content. Which is why, more or less, I mean, it was pretty effective last time. A lot of the stuff that I did ended up being questions on the exam. So I'm hoping I'll be fortunate again. The only thing is, this time I ended up having a lot more content than the cardio exam, which is kind of annoying. There was, for the cardio exam, they had like 60 things that they told me to remember. For this one, they had like 90 things. I think that maybe their sheet was a little bit less specific. So there's actually more questions on this Kahoot than there was for the cardio Kahoot. But hopefully it will cover that content still. Um, for that reason, though, because there was more content, this has about 80% of the content. I wasn't able to fit the rest of the 20%. That stuff is going to be put onto a separate Kahoot, which I will be going over tomorrow morning. So this will be like the bulk of the exam, what I feel like will be on there. And if you guys have time in the morning, we can go over that as well. I'm going to be back at, I'm probably going to do 7 a.m. tomorrow for the second Kahoot, but you can tap in anytime. And after I do the second Kahoot, I'm going to go back and do this one as well. So if you're not feeling prepared, hopefully this will do it. A lot of this is review. I mean, like it's like signs of infection. What is artificial immunity? What is passive immunity? Signs of shock. A lot of this is stuff we already know. So, in fact, I forget who said it, but one of the professors just said that it was like the easy exam of the year, supposedly. So hopefully that turns out to be true. Really fast, I'm going to start sharing my screen, and we'll get started here shortly. I have to figure this out again. Okay, cool. Are you guys able to see what I see? I'm assuming yes.
Yeah.
Okay, cool. All right, I'm going to give it 2 more minutes just to let more people filter in, and we'll be good to go. And if you guys have any questions at any point, definitely tap in. I have literally been making this like for the last like 72 hours. My brain isn't like 100% there. So if I say something and it's like just wrong or like I seem confused, feel free to jump in. What on earth? Maybe that wasn't me. Maybe it was somebody else. People are waiting. What? I don't know how Teams works. Okay, whatever. But yeah, if anything seems off, definitely let me know immediately.
Hey, Duck, do you know if there's a game pin for this?
A game pin? It hasn't started yet. Once I start it, there'll be a pin.
Awesome. Thank you, bro. Appreciate you.
Actually, you guys can go ahead and start joining. Let me start this up. Making sure that this stuff doesn't. Yeah, cool. All right. And I won't be able to see anything in the chat log. Be aware of that. If you missed what I said when I first opened it up, this is basically going to be all content from the reviews. They do seem to go over the same content in every review, just regardless of the professor. So I feel like it's a pretty reliable way of gauging what the exam is going to be. And also, if you missed it, I am going to be back around in the morning. This is going to cover probably about 80% of the exam. I'm still creating the remainder, and I'll be doing that in the morning at 7.
Hey, Duck, quick question.
Yeah.
Do you know what chapters you roughly left off?
I didn't leave off chapters. I just left off specific content. Did you guys get the email regarding like the charts to look at and stuff? Because that's a lot of the stuff that I left off.
Okay.
I'm gonna go through and add all of that tonight.
Okay.
But it's mostly just the charts. I just didn't want to open my book. Okay, I'm a terrible human. That's why I didn't do it. So.
Duck, literally half of those charts that she gave us just aren't correct, so I can't find them either.
And well, I still have a lot of the information from the charts because they'd be like, "Oh, look up this chart, but this is what it says." And so I just didn't look up the chart. I just went off what they said. Okay, but like, you know, whatever. Just I still would review. I know that I think it was Penelope that sent that out that said like, "Oh, you know, look at chart blah blah blah." I would look at it because they both stressed it, both of the professors. So I think there is gonna be questions that are based off of those charts. Okay, I'm gonna give it. You know what, let's just go ahead and start, and if anybody else needs to join, they can. Alright. Cool, let's do it. Do you guys see a box at the top that says presenting? Or do you guys not see that?
Yeah, we see it.
Yeah, I don't know how to get that off the screen. Whatever. Oh, it went away. Okay. Okay, so, yeah. So, you guys are going to have to know this. They brought this up several times in the review. If they are older individuals, then you need to be assessing them to because they might be more affected by drugs, and they might be affected for longer durations. So a smaller dose is necessary for older patients because they have like the declined renal and liver functioning, and you should expect older patients to have the effects of anesthesia for longer periods. So this is kind of backwards. You would expect that older adults would be under the influence of anesthesia longer, not younger adults. This is probably going to be a question in some regard, so just be aware that their clearances are a lot slower.
Hey, Duck, were you planning to record this? I know a couple people asked
Oh.
about that.
Yeah, no worries. I'm recording it right now, so I'll be posting it afterwards. Okay, so just to discuss this, the major risk factors for suture dehiscence are going to be excessive vomiting and excessive coughing. Basically anything that's going to put a lot of pressure on that chest wall. They really discussed a lot about abdominal sutures. We're not talking about, like, we don't have to go very in depth on sutures on, like, the legs and arms and stuff like that. But just be aware, the ones that they really hit in the lecture and then the reviews is excessive vomiting, which we're going to treat with antiemetics, and excessive coughing, which we're going to hit with antitussives. And there's going to be more on this throughout, but just be aware that's a thing. And I'll get better into the groove of explaining stuff as I go along. I just have to, like, get into it.
Also, when I was in O'Brien's review session at 4, she said if you guys study, like, it's really straightforward. This is the easy exam of the semester.
And yeah, she said that this was considered by other classes to be the easy exam. That questions aren't really meant to trick you on this one, so hopefully it will actually show up that way. But that being said, there is still a good amount to know. But if you study this stuff, it shouldn't be as hard. Okay, so the higher risk of infections. This is kind of like a list that you just have to know for this exam. So like obesity, malnourishment, impaired skin integrity, immunocompromisation. These are going to be like the main risk factors for infections. Opioid use. I mean, you could debate that, like, oh, if they're regularly using opioids, then they could be a drug addict, and that would put them. But this doesn't indicate that they're a drug addict, because anybody that uses regular opioids is not necessarily a drug addict. It could just be somebody that uses pain medication. So yeah, opioids do not cause immunocompromisation. Okay, moving on. This is just kind of like a random detail that they just threw in there, so. Okay, cool. So yeah, just kind of like a random detail. But another thing to mention here is that respiratory distress can display differently in different groups of people. One example that was used in Penelope's review is that instead of being weak, an elderly patient might be especially confused. And as you might remember, confusion can be a sign of respiratory distress in elderly patients. So just be aware and be on the lookout for respiratory distress following anesthesia. Okay, so let's discuss this really fast because I can understand how you guys might be confused. So there's 4 major groups that we need to look at. There is natural immunity, there is artificial immunity, Okay, so made by man or made by nature, if you will. And then there is passive immunity, and there's active immunity. The big thing you need to know between passive and active immunity is that in active immunity, you yourself are creating the antibodies. With passive immunity, the antibodies have already been made for you. So in this example, we've got passive artificial immunity. This means that antibodies have already been made for us by a human with our technology, and they've been injected into us. So that's why it would be snake venom antibodies. We did not create those antibodies. They were provided to us. So it's passive. It would be passive natural immunity if it was, okay, the example in this case would be the mother to a newborn, where antibodies come from the breast milk into the child. Probably one of the best things that you can remember about passive immunity is because we are not producing them ourselves, it's temporary. So, like, for an example, this person has had a snake bite venom. They just got a snake bite. If they're injected with these antibodies, they are not permanently, like, immune to snake bites now. They're immune right now, but in the future, if they get bit again, they're going to need more antibodies. Whereas if this was active immunity, they would be able to create more antibodies in the future. So yeah, it's passive, meaning they did not produce the antibodies, they were provided to them. And it's artificial, meaning that it was created of human technology. All right. And there's a few of these on here, so if you guys are confused about that, hopefully that will help clear that up. And I do expect there to be a question of this caliber on the exam.
Hey, Duck.
Yeah.
Can you zoom in a little bit? People, like, can't see.
Oh, yeah, of course. Hopefully, we'll see how it looks on this next one, but hopefully that will have enlarged it.
Do you know the code, Duck?
Oh, that is a great question. Ooh. There we go. Can you see it?
Yeah, thank you.
Okay, hopefully that's, like, big enough. Can you guys read the text in the middle?
Yeah.
Okay, cool. So we're talking post-anesthesia care unit. If we're looking at cardiac status, we're looking for those signs of shock, which, as you guys might recall, include a decreased blood pressure and an increased heart rate. So this is a correct statement. You're going to see this resurface a few times with some different answers, so just be aware of that. But this is a correct statement. Wow, yeah. The blowing up is really messed with the font, but... Ooh, good job. I already feel like, that you guys already know what passive is now. Woo, thank goodness. This is a lot of text. Take your time. You got a minute. Okay. Good overall. I can understand why there'd probably be some confusion. So yeah, going over it really fast. Okay, so he's in constant pain. His pain medications aren't helping. He wants to see if there's anything that you can do as a nurse that would help him, assuming that it's not going to interfere with his back pain. So repositioning is one of the things that we're expected to know helps with pain. So just be aware, on the list of things on the study guide that we need to know, repositioning is one of the critical parts. Also, they put a lot of emphasis in the review sessions that elderly patients, if they're experiencing pain, having a loud environment makes it worse. So offering to turn down his TV can help him to better manage that pain. They use this TV in like 3 different examples, so I just wanted to make sure, just in case it was an exam question, that you're aware that turning down that TV can help elderly patients manage their pain. And then deep breathing exercises, guided imagery, these are just like our basic kind of ways of managing pain. But we, as nurses, we do not have the authority to move him up to the next stage of pain control. This would be something that his physician would have to do. We have to give him comfort measures, but we can't say, okay, now it's time for morphine, or whatever have you. Okay, moving on. Okay, great job, guys. During the review, they mentioned that there's probably going to be a question where a patient that is returning from anesthesia requires reorientation. So just be prepared for that in some form or another. Yeah, they're just going to require some form of reorientation. I can see why you'd say 2200. There's kind of 2 ranges that we're looking at. 4000 is the one that you really have to know. In both review sessions that I went to, they said 4,000 for Tylenol, and then they basically ignored the lower limit, which is you would use 2,200 if it was like, okay, they're on this medication that also contains Tylenol, and you don't want to, or acetaminophen, and you don't want to allow them to interact. But because this is a normal healthy adult that's assumed to not be on any other medication that would involve it, think 4,000. And if you see it on the exam, I can almost guarantee you to be 4,000. But what I'm thinking is this is probably going to be one of the math questions. We're probably going to have like, okay, they took this much at this hour, they took this much at this hour, and then they had Norco, which contained this much in milligrams. And then it would be like, is this acceptable? Or something like that. Just remember that 4,000 limit, and you should be totally fine. yeah, obviously those are the things we're going to want to check. So good job, guys. Okay, so I apologize in advance, but this is one of the things that they said to know during the review. If a patient returns from surgery and you're checking their pulses and you notice that there is some kind of discrepancy between the apical pulse and one of the distal pulses, so one of like the radial or pedal pulses, then you need to suspect a cardiac dysrhythmia. It's unclear as to which one it would be, but there is some kind of heart condition going on. There's no way of telling otherwise exactly what it is. And also, I am so sorry to everybody that selected this. But so cardioplasia means the heart stopping intentionally. That's like when you do it for a procedure. And I just put distal in there, so it sounded right. But I feel you. But just be aware that if you see some kind of discrepancy between apical pulse and a distal pulse on the exam, it's likely caused by a cardiac dysrhythmia. They put a lot of emphasis on that, so I just want to make sure I fit it in here. Okay, so let's look at this real fast. So it's active immunity, okay? So that means that the individual is creating their own antibodies, okay? That being said, it's also artificial, meaning that somebody is, or I should say, it's created of human technology in some way. So I know some people chose B, the blue. This has a child becomes infected by chickenpox and is now immune to the virus. This would be active immunity because he's creating his own chickenpox antibodies, but it is not artificial because there is no human technology being used here. It is just his immune system finding a pathogen and creating antibodies. That would be active natural immunity, not active artificial immunity. And then as for the snake venom, that would be passive artificial immunity. And then the breast milk would be passive natural immunity. But overall, great job, guys. And there are a few more of these, so you still have chances to practice. Great job. I know exactly why you would say general ambulation, because I would personally assume that ambulation would be a big risk factor. But as far as this exam is concerned, excessive coughing, which we treat with antitussives, and excessive vomiting, which you would treat with antiemetics. So great job, guys. So, Penelope literally brought this up like 5 times during our review, and every time she was like, "And what drug do we use for nausea and vomiting?" I think it's going to be on the exam at some point, Zofran. In fact, if I had to guess, if you remember in our last one, the risk for the abdominal suture rupture, the excessive vomiting is one of the potential causes, in which case you would administer Zofran because it's an antiemetic. So if you see anything about excessive vomiting in regards to abdominal sutures, know that we would treat it with Zofran. If you're not familiar with Zofran yet, be familiar with Zofran. I can almost guarantee you that this will be an answer at some point on the exam. So Zofran, antiemetic for nausea and vomiting. I have a few questions about Zofran, so it better be like burned into your head by the end of this. I'm sorry if you thought I was trying to trick you, but no. Yeah, we want to keep them on continuous O2 sat monitoring. PCA pumps are designed in such a way that they don't provide an overdose to their patients. That being said, there's always a risk, especially if we're talking about like drug interactions. So you do want to keep them on O2 saturation monitoring, because you do not want their O2 saturation to get low and that PCA pump still administer medications that could further drop their O2 sat. So great job, guys. I'm going to go grab a drink. I'll be right back. Okay, great. So, just to mention this, okay, so the other 3, whenever you get one of these questions on one of my Kahoots that's like, everything except for blank, it's basically something where you have to know what all the things are. This is kind of like a SATA question in reverse, because Kahoot doesn't want me to give you guys SATA questions. So, key considerations and effective antimicrobial drug treatments. Let's see here. They continue treatment for the entire prescribed duration. We know this. It's a big issue, adherence, all that good stuff. We want to make sure that it's the right microbial drug class for the specific microbe. We don't want to give like a antifungal for a bacteria. It won't be effective. So we want to make sure that we're using the correct kind of drug class. And then correct route, correct dose. Obviously, you don't want to like... If it's, a IV antibiotic, we don't want to just apply it to their skin. Okay, it's not going to be very effective in that case. Now, why is this one wrong? Well, it's not really a goal of antibiotics to kill all of something, typically. So, like, for an example, take E. coli. So, E. coli infections are pretty normal. They're pretty typical in a healthcare setting. But we don't want to kill all E. coli, because E. coli is actually a normal part of your intestinal flora. So if we kill all of them, we're going to be disrupting your intestinal flora. So we don't necessarily want to kill all of a targeted microbe. We just want to get it into a controllable state that makes sense. So this is not a typical key consideration with antimicrobials is to kill everything. So, okay, moving on. Awesome. Okay, so if you don't know this already, definitely get it into your head. So older adults and any adult that has compromised kidney or liver function is basically going to get a greater effect out of the same dosage of medication compared to a younger or a non-compromised adult. So 10 milligrams of morphine will likely have a greater effect and will probably last longer as well in an older adult or in somebody that has kidney or liver disease. So just be aware of that. This is going to come up in some fashion as a question, so just kind of know that that effect exists. Moving on. Okay, cool. Yeah, so like I said, Zofran will hopefully be burned into your head by the end of this. It's going to be our common medication for nausea and vomiting. Moving on. Kind of a random piece of trivia that we have to know. Okay. If you weren't in the review sessions, and I don't blame you for not knowing this, kind of a random piece of info, but beta blockers, if a patient is regularly prescribed them, we don't want to stop giving it to them. Because if you recall, if you stop beta blockers on somebody that takes them chronically, they can have a reflexive increase in their blood pressure and heart rate. So we don't want to do that before they go into surgery. So beta blockers can be continued into surgery, but you want to make sure the physician is aware because it can have effects on like the drugs that they use. So just be aware of that. And they put a lot of emphasis on this in their reviews, so know it. It's probably going to come up at some point. Beta blockers can be used, but make sure that the physician is aware that they're taking it. Okay, moving on. Okay, I think there's like 3 people that aren't paying attention, so no worries. I might just skip. Yep. I think we know this. There are like 2 or 3 areas in this exam where they went over and they were like, do you let UAPs assess the patient? So if you see it, no. They do not assess anything. I don't care if it's spinal anesthesia. I don't care if it's a pain level. It doesn't matter. They shouldn't be assessing anything. Nor should they be providing education. If you see a question that regards to delegating to a UAP, like 90% of the time, they're not allowed to do it. So just keep that in mind for the exam. Don't lose easy points. Okay, so you might have thought that I was trying to trick you, okay? But this was just off of her PowerPoint. They look very similar. They have similar effects, but 1 milligram of hydromorphone is roughly equivalent to 5 milligrams of morphine. So be aware of that. The reason it's an issue is that it's a common medication error to provide patients with hydromorphone rather than morphine. And as you can imagine, if you think that hydromorphone is morphine, and you give them the normal dosage that they would have in morphine, you're giving them 5 times as much as they normally have. So a lot of patients go into respiratory distress from hydromorphone overdose. I expect this in some form to be a exam question, whether it's like, okay, technically they could be substituted for one another, but you would not be able, there would have to be like math of some kind involved, and we wouldn't be able to make that call. Just be aware that it's a very common medication error, and the hydromorphone is 5 times as potent as morphine.
Is the hydromorphone 5 or is it 10? Because I thought it was 10 times more potent.
In the PowerPoint it said 5. I don't know if it gave us different information somewhere else. Does anybody else remember 10?
I think in the voiceover she said 10.
Yeah, she said 10 in the
10,
But I remember
think she said
5.
a different
I
drug.
feel you.
Okay.
I think it was a different drug that was 10. I think it started with a D. You know.
It's Dilaudid, the other name for hydromorphone.
Oh,
Dilaudid was
complicated. I guess just remember that it's more potent, and if you see it on this Kahoot again, just pretend that it's 5 times, just to be totally safe. But yeah, if it's going to be on the exam, the big important thing is that they're not like 1-to-1 compatible because they look and have similar effects. Just remember that, but it probably will come up at some point on the exam. And I'm sorry to people that were like, oh, it's 10 times. I know that feel. Okay, so I knew that this would be a mean question. So let's discuss this really fast, because I can almost guarantee you that you're going to have something like this on your exam. Okay, so he's fresh out of surgery, right? He's still partially sedated, but he's conscious more or less. Okay, he's obviously not alert and oriented, right? He's talking to somebody who's not there. He's speaking nonsense to you, okay? So here's where the issue comes. He seems to be in pain, okay, but we can't ask him about his pain. If you tell him to do something on a scale and he says, okay, yeah, 2, first of all, the fact that he could answer that question is awesome. But you can't trust what he says because he's not alert and oriented. These scales, this 1 to 10, and this intensity, location, quality of the pain, those are great if you have a patient that understands what's going on. But when you have a patient that is obviously not alert and oriented, these are not trustworthy scales. So in this case, in case you're not aware, the nonverbal pain scale, this is what we use for patients that are, like, for example, sedated, like fully sedated. They're asleep or they're not able to verbalize. This is what we would use. Now, an important thing about the nonverbal pain scale is that it actually does incorporate what the patient says or does. So, for example, if a patient that's partially sedated says "ouch" or something, that would go into the nonverbal pain scale, even though it's technically like a verbal utteration. In the same way, the stuff that he's saying here, where he's like, "I'm hurting," that would go into the nonverbal pain scale. But we can't take him for his word for how much pain he's in or how that pain is while he's clearly not alert and oriented. I expect there to be some kind of question along this vein, where you're going to have a patient that is either partially sedated or fully sedated, and it's going to say, what pain scale would we use? Now, mind you, I didn't say exactly like what pain scale do we use, but I said, how would you? And at that point, scale of 1 to 10, they're not alert oriented, they can't make that decision. Intensity, location, and quality, they're not alert and oriented, they can't make that decision. You have to be the one to decide how much pain they're in. I realize they'd be like, oh, but like maybe they're alert and oriented enough. Like, but you can't trust that, essentially. It's because, okay, what if they're not really in pain? I know, like, mindfuck shit here. Maybe they're imagining the pain. But if we give them morphine and they're not really in pain, we've just given them morphine that's not going to help them. So this is why you can't trust them when they're not alert and oriented, if that makes sense. So be aware of that. They have to be oriented before you can give them these kinds of questions. Okay, good job, guys. I'm sorry if I betrayed you with that question. I know that was a hard hitter. Okay, so I can totally understand why you'd say A, okay? This is something critical that you're going to need to know for the exam, okay? So if they come in from surgery and we take their temperature, they're hypothermic, right? That's one of the things we're checking for. If they're hypothermic, we have to assess the rectal temperature as well to confirm. That's the first thing that we have to do after taking their axillary or oral temperature. I know that you're probably like, oh, I don't want to be invasive or whatever, but we have to know their core body temperature. So as soon as you get that axillary, if it's hypothermic, we move to rectal. If it's rectal, then we're talking the bear hugger or potentially warm saline. That's like a special treatment we normally don't do. Normally bear hugger. But I like where you're going if you selected A, but you have to do that second check. It's essential. And there will be another question on this, so just be aware that we move from that axillary or oral to rectal for confirmation. Okay, good job, guys. Yeah, so once again, this is an accept question. You really should avoid the hypertension. Remember all of the others. You need to know that opioids are going to cause constipation, they're going to cause sedation, they're going to cause nausea and vomiting. Okay, they're having nausea and vomiting. What drug are we going to treat that with? We're going to treat it with Zofran, the antiemetic drug. It's going to come up at some point, so just be thinking that way. And yeah, you can think about like, oh, how are we going to treat constipation? Okay, we can't really treat the sedation. That's usually something that you just have to wait for it to wear off. But be aware of the side effects of opioids: constipation, sedation, nausea, vomiting. They are a potential fall risk when they're under the influence of opioids as well. Okay. Alright, I love you all. The two people that said that it was effective, I love you guys too, but you guys got to know this. Hand sanitizer. Very important to know that it is ineffective against C. diff. C. diff is kind of an exception. It's the 0.01% that the the hand sanitizer doesn't affect. You have to use soap and water. That's all that you can do for C. diff. And it's important that you know that, because in the Medsurge floor, I've cared for C. diff patients. You have to know that when you get out of there, you can't just use the hand sanitizer, or you could be bringing C. diff to other patients' rooms. So be aware of that. Soap and water for C. diff. Okay, we discussed this a bit. Oh, look how smart you people are. Holy shit. Okay, partially sedated. You cannot trust her testimony. I know you want to do the 1 to 10 scale. I know you... Okay, I don't know why you want to do faces scale. 1 to 10. We're using 1 to 10 with fully cognizant, alert, and oriented adults to see where they are on the pain scale. The faces scale we're using with children. They're too young to fully understand the 1 to 10 scale, so we're just showing them a frowny face and saying, is that you? That's the only time that you really use the faces scale. So instead, because we cannot trust her testimonial, we have to look at her and we have to say, okay, is she wincing? Is she trying to like curl away from pain? Is she making guttural noises? We have to kind of decide, if you will, whether or not she seems to be in pain. Kind of fucked up, but like we can't trust her testimonial. So great job. Yep, we're going to use the checklist of nonverbal indicators. I know it sounds fake if you haven't read the chapter, but it's a thing. And be aware, I expect this to be an exam question at some point. Sedated patient, you're going to use that checklist of nonverbal indicators. Not a scale of 1 to 10. They're not cognizant. Good job, guys. Non-pharmacological. Okay, so she specifically, while I was Penelope, when I was in her review session, she was like, "So what are the main non-pharmacological pain relief measures that we're going to use?" And I'm sitting there, I'm like, "What, like heat?" She's like, "Specifically repositioning, cold compresses, and warm complexes." She just like was reading these off a list: repositioning, warm compresses, cold compresses. If I had to guess, it's probably a select all that apply, or a question like this, where you're choosing something outside of those three norms. A PCA pump is a pump for medication, meaning it's a pharmacological pain relief measure. How is somebody waiting in the lobby? Well, I hope.
I admit it hurt. Don't worry.
Okay, I was gonna say. Okay, so yeah, it's pharmacological. So, therefore, it is not the correct answer. Remember, repositioning: warm compresses, cold compresses. Probably will be on the exam at some point. Okay, let's discuss it. So, active immunity. Active immunity is where you are making your own antibodies. Okay, so you have been exposed to the virus in some way, and your body has adapted to form its own antibodies. Passive immunity is where you do not create your own antibodies. Something else makes them for you and gives them to you. Okay, so this sentence is describing passive immunity, not active immunity. I know it sounds like a good and well-worded sentence, but yeah, it's passive immunity that would have been correct here. Okay, cool. Just to discuss this really fast. So, if they're coming out of anesthesia, these are the two main respiratory benchmarks that we're looking at. We don't want them to be bradypneic, so we don't want them to have too slow of breathing, so under 10. We don't want an oxygen saturation under 95%. It kind of seems weird to me because I've seen so many patients that are under 95%, but that is what they consider to be like the lower limit when you're coming out of anesthesia. They will not release you to Medsurge until you're over 95% O2. This will come up at some point later in the Kahoot. She put a lot of emphasis on these respiratory benchmarks. I think she brought them up like 3 times. So just remember, it's bad if they're under 10 breaths per minute or if they have an O2 saturation of less than 95%. Cool. This is from the sepsis care bundle from the last exam, if you recall that we're checking the lactates, we're checking the blood culture, and then we're administering the antibiotics. The reasoning being that if you perform the antibiotics before you take that blood culture, the blood culture is going to be incorrect because it's going to kill off all the bacteria that you're trying to test for. The time periods there, I just made up. So those, unfortunately, aren't correct. Just be aware that we're going to take that blood culture before we give the antibiotic. I can almost guarantee that this is going to be a question because I'm pretty sure, yeah, Penelope specifically mentioned this as a question. So know it, okay? First blood culture, then antibiotics. Cool.
Sarah also said it in her review session.
Okay, cool. Then that just confirms it. So this is a free point. So know it for sure.
Hey, Duck, I'm sorry, I stepped away and I know you probably went over it, but the last question I got wrong. So, by benchmark, did you mean, that's the lowest it should be?
So the benchmark is really just kind of like another word for a test. So, yeah, more or less. It should never... Is this the respiratory one?
Yeah, because like I thought it should have been over both of those, and then so I was confused.
Oh, I feel you. So on that question, it said it asked if it was asking if it was a true statement, and the statement said that in PACU we want to make sure that they have a respiratory rate of, or no, it said. I guess I have to like read the question, but I know that it's like, is it correct that it is bad if they're under 10 or under 95%? I know I'm like saying it backwards, but.
Okay. Yeah. No, I read it backwards the way that you were saying it, so that makes more sense.
Yeah,
it just confused me.
That.
No, it's okay.
All right, moving on. I don't know if somebody said true to spite me. But so yeah, if you see any question about them performing an assessment, nip it on the bud, because they should not be performing any assessments. That being said, she specifically mentioned, like out of nowhere, she was like, would you let a UAP assess a spinal analgesia procedure? And I was like, no. She's like, okay, good. And then like she moved on. I was like, that's really fucking random. So I'm just saying, if you see a UAP performing assessments on spinal analgesia, they shouldn't be doing that. Okay, moving on. Okay, so if you said the void one, I respect the hell out of you, but no. So, and here's why. The post-anesthesia care unit, their entire job is to assess for adverse effects of the anesthesia. It is not good for them to have not voided, but that is not the job of PACU. That's for the Medsurge floor that they get moved to pay attention to. That being said, yes, if they don't, 30 mLs for 2 straight hours, yes, it's a sign of shock. But the big things that PACU is looking at is respiratory status. They want to make sure that it's over 95% and a respiratory rate of at least 10. They want to check neuro status. They want to make sure that they're at least mostly oriented. It's okay if they have to rouse them a little bit, but if they're like totally out of it or just straight up asleep, they can't be discharged. And also, there is some cardiac monitoring as well. Like, they don't want them to be like, you know, in fucking cardiac shock essentially, but for the most part, it's that respiratory and neurological assessments that PACU pays attention to. The rest, that blood pressure, that void, that's mostly assessments that the Medsurge floor is going to be paying attention to once they are received from PACU. Okay, but I totally see why you'd say the urine thing, especially after the last one. And she did mention remembering that. She did mention that you should know the 30 mLs for 2 straight hours, but we're supposed to know that after they get out of PACU, not while in PACU, if that makes sense. Okay, so I can totally understand why you might get this wrong. Going into this, I had no idea what a left shift in white blood cells was. So here's the idea. So you have a patient that is experiencing an infection, okay? Usually a severe infection or sepsis. You're going to see a left shift. What that is, okay, so the body sends all of its white blood cells, its mature white blood cells, to go fight the infection. And the process of that, white blood cells are going to die, okay? So white blood cell counts are actually going to decrease in the initial stages of the infection. So in order to compensate and in order to fight that infection, your body's going to increase the production of white blood cells, okay? And so in the early stages of the infection, you're going to see a ton of immature white blood cells. They're still growing up, preparing to fight that infection. So the left shift, it's referring to the age of the white blood cells. So if it were on a graph, you would see that there would be more white blood cells that are younger than there are older, more mature white blood cells. And then this balances out after a few days because eventually those immature white blood cells grow up and then they're mature and then the graph kind of levels out. But you should know that in those initial stages of a severe infection, you're going to have that left shift where in the blood you're going to have a ton of immature white blood cells that aren't ready to fight that infection yet. If you see left shift on the exam, just know that it's referring to those immature white blood cell count. Okay, and she put a lot of emphasis on that, so I just want you guys to know what a left shift is. But good job, guys. Okay, great job, guys. Already seeing a lot of improvement in this. You have a patient that is sedated. I know they're able to speak, okay? I know that, like, you want to take them at their word, okay? But patients that are sedated are not normally considered alert and oriented, and thus you cannot take their word for how they're feeling. Once again, we would be using the nonverbals as our scale of pain. And especially so, we cannot increase prescribed sedatives. We can't just be like, oh yeah, here, have some more sedatives, as long as I document it. You're a nurse. You can't do that. Technically, if he was more alert, if there was PRN morphine, you could debate that. But because he's sedated, we don't have that authority. We can't tell that he is fully cognizant. So just be aware of that. We're gonna try to avoid that. If you see that they're sedated on the test and they try to give you some kind of pain scale, you need to know that you can only trust their nonverbals. Okay, and that's assuming, okay, yeah, if they're like 2% sedated, like they came out of surgery 12 hours ago and they're just like ever so slightly drowsy, you could make an argument that they're now alert and oriented enough to make that decision. But most patients that are under sedation, they can't be given that sort of authority. Okay. Great job. So decreased renal function, decreased liver function. We're going to see slower filtration of those drugs, so they're going to stay in the system for longer. I would expect there to be a question of some kind referring to the fact that they're affected by lower doses and that they last longer in their bodies. So just be aware of that. Older adults and anybody that has impaired kidney or liver function is going to see that. Okay, so let's discuss this. Foley cats. 2 things that I want you to know. First of all, we should prioritize removing them as soon as possible. We don't make that decision. The physician does. That being said, you don't want a catheter to stay in a patient for longer than it needs to. They're very common sources of UTIs, so getting them out fast is a relative priority. That being said, because they harbor a lot of bacteria, we also want to clean them often. Okay, I can understand the mind process of like, ooh, we got to leave them alone as much as possible, but remember that they're in a damp, warm location next to a portal of entry into the body. So bacteria are going to want to grow there. So we have to give them attention. We do have to clean them regularly. That being said, we never want to clean them in an inward motion toward the urethra. You're just going to be pushing bacteria into the urethra, which is not optimal. You could kind of debate this one, be like, ooh, avoid them at all costs. Okay, you do want to avoid, Foley caths if you can, but there's a lot of times that they just make everything much easier on the patient and us as healthcare workers. We don't want to really avoid them at all costs. And I also made up the 4 times. So I'm sorry about that. I tricked you. But yeah, the big things you want to pay attention to, clean them often, make sure that bacteria gets out of there, and remove them as soon as possible. And when you're cleaning them, make sure to do an outward motion away from the urethra. Okay, great job. Okay, we're talking about those lab values and what's considered abnormal. I'm not doing exact normal ranges. Okay, so you need to know this. It's probably going to be a select all that apply question, okay? These are values that potentially would stop a surgery if they were off. First of all, normothermia means that they have a normal body temperature, okay? So it shouldn't be stopping anything. That being said, INR, okay? INR is going to be their clotting factors, okay? So if we have decreased or increased INR, it's going to change how their body responds to clotting. The surgeons absolutely have to know that. It could potentially destroy their surgery depending on what body system that they're targeting. High or low potassium, same idea. We don't want to have cardiac abnormalities during a surgery that is invasive. And hemoglobin or hematocrit. If a patient's anemic and goes in for a surgery that involves a lot of blood loss, it could be potentially fatal. So we want to make sure that if clotting factors, any kind of like anemia, or potassium issues arise before a surgery, that we alert the physician, and that surgery is probably going to be postponed until that can be corrected. You should know for the exam the normal values for these Unfortunately, I don't have a list in front of me with what like normal INR and stuff is. That's something that I'm doing tonight. But at least write it down that you need to know INR, hemoglobin, hematocrit, and potassium. There is 2 others as well, but Penelope specifically brought up these, which I found really suspicious, and then they repeated on the other review session. If I had to guess, what it's going to be is it's going to be a select all apply question that's like, which of the following lab values would warrant contacting the surgeon? And it's going to be like a potassium of 3.0 and an INR of blah, blah, blah. And you're going to have to go through and you're going to have to say, oh, that's unusual, and I have to contact the physician. And, oh, that's unusual, and I have to contact the physician, etc. And it'll be a select all apply. If I had to guess, that's what's going to happen. So just know your normal values. Okay, moving on. This box of cookies over there that is like staring at me, and I'm trying so hard to not eat it so I don't like bother you guys. Oh god, I have to like put it out of my sight. Okay. Woo. Okay, and I'm sorry to whoever chose green. I made up both the MREP pain assessment and the PDSA. I hope that they sounded very official, but I made them up. So yeah, patient self-reporting is going to be your go-to for pain assessment. This was brought up on both reviews. I expect there to be a question of some kind that's going to ask you what the most reliable way to measure pain is. Just know that the gold standard of pain is always going to be patient self-reporting. Specifically, it's going to be subjective. Objective methods of pain measurement, which is where we pull out like that. Frankly, there's not really like an objective way of doing it. You can't prove that somebody is a level 7 on the pain scale. So you're never gonna have objective standards of pain. Just know that patient self-reporting is the gold standard as far as our credibility and being able to believe somebody's pain. We're always going to believe the patient, unless they're sedated. Okay, then you can't trust them. But any other time, patient self-reporting. Okay, moving on. I'm just going to say, don't select B. I know you probably already selected B. Don't do it. Okay, I know it's right, but this is not what I'm looking for.
Duck, dude, go eat your fucking cookies. What do you got?
Dude, they are, I forget what they're called. You know, like the best cookies, though? Can you see me? I don't know if you guys can see me. They're these. Can you see it?
Oh, fuck yeah, dude.
Those fudge stripes.
Yeah, fudge stripes. Yeah, I know. But no.
Eat them. Eat them, Duck.
The little elf guys are superior.
Ooh. Hot takes. Hot takes.
I ate a bag of them, so I'm not allowed to eat anymore. Hey, nobody chose B. Thank you guys. Okay. And see, now I have a fucking cookie in my mouth as I need to talk. This is why I want to get the cookies. Okay. Yes, technically the intubation process can cause rapid destruction of tooth enamel. That's grand. The big issue, though, with both intubation and those catheters, the Foley caths, they both are big, open, wet portals for bacteria to enter. It's essentially a constant line of wet area that bacteria can just slide right down to get into the body. That's not good. So just like the Foley catheter, we need to clean it to make sure that bacteria doesn't form up and spread to the rest of the body. So intubation is especially threatening because if we don't clean the mouth, I mean, think about it. It's a warm, wet place that has a lot of nutrients for bacteria to grow. And they do. And they'll start in the mouth, and then they can move and do stuff like meningitis. They can infect the brain. They can move into the lungs and form pneumonia. In which case, I'm pretty sure it's called ventilator-associated pneumonia, which may be on your exam. Just know that the reason that we have to do regular oral hygiene is because, unlike a normal mouth that's going to be closed all the time, they're always going to have a portal in, and that patient might not be swallowing effectively, which means that they're just going to have a breeding ground that bacteria can grow in. We have to make sure that they can't survive. So yeah, just know that there is an increased risk of infection from those intubated patients. But great job, guys. Okay, I'm eating my cookie. Cookie went down the wrong hole. Oh, I get punished constantly for eating cookies. Okay. That's what I get. Okay, so we discussed this. So unless you have me muted, hopefully you know this. Really fast to discuss. So left shift, we discussed earlier. It's where there is an increase in younger white blood cells, immature white blood cells, and a decrease in the mature white blood cells. It's because the white blood cells go off and die fighting the infection, and the body tries to compensate by producing more white blood cells. So you're going to see that increase in white blood cell production, and you're going to see a decrease in the mature white blood cells. So just be aware of that. There's probably going to be at least one question that refers to the shift to the left. I think that as long as you know that there's an increase in immature white blood cells and a decrease in mature white blood cells, you'll be fine. Also, know that it's like the initial stage. This isn't something that continues, because after a day or two, you're going to have these white blood cells are going to grow up, essentially. And you're going to have the body flooded with mature white blood cells, which will die, and then there'll be another generation, but there isn't going to be quite the same shift to the left that there is in the initial stage. Okay, moving on. Is this something you have to consider? Come on. Okay. It's an effective antiemetic drug. You need to know that. Zofran is going to be your antiemetic friend for this exam. We're going to be, if you see that they're nausea, vomiting, we're going to whack them with the Zofran. Remember that for this exam. Okay, so I know why you would select opiate abusers. Okay, I know your brain was like, oh, that's an opiate abuser. They take analgesics. Opiate abusers, but no. It's elderly individuals. The reason being that, like we mentioned, they have that decreased renal and liver function. So analgesics are going to affect them more than other groups. That being said, opiate abusers, you would probably have to use a higher dose on those. But that wouldn't be enhanced caution. That would just kind of be something you'd have to consider. And you're not even the one prescribing the medication anyway. But yeah, just be aware that with elderly individuals, they're affected more by the same doses. So we're going to be a little bit more cautious with them, as well as anybody that has liver or kidney issues. This is kind of something you have to know. It's off that chart, so. Okay, so let's discuss, because I know a lot of you people don't know this chart like the back of your hand. There's two things I want you to know for this exam from the SCIP chart. Prophylactic antibiotics, okay? These are the antibiotics that they give people while they're in surgery, essentially, just to help prevent infection, okay? And then there's also the Foley catheter, okay? This is to help collect urine that otherwise would have to go somewhere during the procedure. So, Foley catheter, prophylactic antibiotics. With the prophylactic antibiotics, we want to discontinue them within 24 hours of surgery. Remember that these antibiotics, we're just using them to help prevent the surgery from causing an infection. So once the surgery's done, they're sewn up, and they're recovering, we don't want to continue the antibiotics. They've served their purpose, essentially. And then we have the Foley catheter, okay? The Foley catheter, you should discontinue 1 to 2 days following surgery, okay, or post-op. So those are the two you need to know. Prophylactic antibiotics, they should be discontinued within 24 hours. And then the Foley catheter should be discontinued within 1 to 2 days of surgery. I know that you guys that did the 1 to 2 days of surgery, you probably were thinking of the Foley catheter, probably got it mixed up, but just be aware of that. This is probably going to be an exam question, either the prophylactic antibiotics within 24 hours, or the Foley catheter within 1 to 2 days. So I would know those two if you don't already. Okay, good job, guys. And that's just off like that random fucking chart on one of the chapters. Okay, I see what you were confused on the benchmark thing. Yeah, so I should have worded that better. Yeah, you aren't trying to achieve a respiratory rate of under 14 breaths per minute. We're trying to avoid that. So that's, I should have said like points or vital signs that you're looking for. So yeah, the reason this is false is because in PACU, the two vital signs that we're checking for that we want to avoid are going to be a respiratory rate of under 10, okay, which would be bradypnea, or a O2 saturation of under 95%. So those are the two things we're looking for respiratory status. Those, if I had to guess, if we had a question regarding the different vital signs we're looking for in PACU, respiratory status is probably the most essential one you need to know. So under 10 breaths per minute or under 95%. I would know that. Okay, moving on. And once again, I'm grabbing more water because that cookie made me fucking thirsty. Okay, so I love you all that did the N95 because I totally know what you're thinking, okay? If you yourself are going into the patient's room, you should have an N95. But for transport, we're just talking a mask. And okay, technically you could get into the details and be like, they should really be wearing an N95. But don't forget that those N95s that we wear are specially fitted for us. Okay, we can't do that for every patient. In addition, the way that airborne pathogens work is that they, oh God, okay, I don't want to like get into all that, but they are aerosolized. They don't necessarily travel on droplets, but as long as they're wearing a mask, most, if not all of it, will be contained. So as long as you get them moved fast enough, they should be fine. I mean, yes, if we could have quickly fitted N95s, that would be optimal. But wasting an N95 for that reason isn't really what we're told to do. We're told to just give them a mask, whether they are droplet or airborne. If you see it on the exam, droplet or airborne, we're giving them that mask, okay? If you see contact, okay, this is dumb and it sounds fake, okay, but there's technically two different ways that they could do it. One, I've heard some professors say like that you are supposed to like, okay, this is the one that I know that I was told to know, was place a sheet over them. It sounds fake. It sounds like a wrong answer, but apparently that's what you do if they're in contact precautions. You place a sheet over them or something to cover their body. Yeah, so just know that, I guess. If they're on contact, place a sheet over them. If they're on airborne or droplet, we're placing a mask over them. We do not put an N95 on them. The N95 is specially fitted for us. Okay.
Hey, Duck. What do we wear for contact precautions? Is it just gown and gloves?
Gown and gloves.
Gotcha. Thank you.
Yep, and then clean mask or just like a normal surgical mask for droplet, and an N95 mask for airborne. I've had some conflicting information as far as like face shields and stuff. I would think that you'd wear like face shields for airborne, but apparently those things vary based on the pathogen at hand. So for the most part, just know if you're doing contact, you definitely need a gown and gloves. If you're on droplet, you definitely need a mask. And if you're on airborne, you definitely need an N95 as the nurse. So yeah, moving on. You guys. Okay. This is just one of the ones that I want you guys to know. Literally, I was going through my review, blah, 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 we're in the infect... What? Oh, okay. I guess I can't show you the... Oh, there isn't media. That's weird. Anyway, I was going through the review with her. We were on the infection chapter. And she's just like, she's looking at her paper, blah, blah, blah. And she looks up at me and she's like, what do you treat MRSA with? And I'm like, I didn't know at the time. That was a few days ago. But it's Vanco. And it just seems like a really random question that she would ask me. So, just in case, know that MRSA is treated with vancomycin. Typically. I'm not trying to trick you. Don't read too much. Like, actually, everybody doesn't love it. But actually, cool. Know that Zofran is antiemetic. Know it's for nausea and vomiting. It's a point. I can almost guarantee you. So just know it. It's in there. It's in your noggin. Moving on. Okay, remember, unlikely to be discharged. Remember that our priority assessments in PACU are going to be respiratory, neurological, and circulatory. Okay, great job. So we're looking for those respirations. Okay, so we want them to have more than 10 respirations. We want them to have an O2 sat of over 95%. So this person has 98%. That's great. They have a respiratory rate of 12. That's great. We could care less about whether they have ate, drank, or went and voided. That is for Medsurge. Okay, so this is not correct. And then as far as blood pressure is concerned, yeah, it's a little bit on the low side, but it's not like they're like hypotensive. They're not going to go into like a hypotensive crisis. And okay, I could see that they have 4 liters of oxygen. Ooh, what how could this person be released? No, it doesn't really matter. They're going to have patients that are on oxygen all the time. As long as their O2 saturation is above 95%, it doesn't matter. Release them to Medsurge. Because, okay, for an example, what if you had a patient that, say, just got out of, okay, I don't know anything about fucking lung surgery, but what if they got out of lung surgery and they have to be on oxygen now, okay? This does not necessarily disqualify them from leaving PACU, okay? And she specifically mentioned, this is what she said in the review, she said, it is fine if they have not voided. It is fine if they don't have an appetite. It's fine if they have not drank, okay? What is not, and it's fine if they're on oxygen, okay? That she made a big point out of that. What is not fine is if they have a low O2 sat, if they have a low respiratory rate, or if they are difficult to rouse. Those are the big 3 that if you have one of those, you're not leaving PACU. And this person here is difficult to rouse, and that's alert and oriented ×1, which they're basically asleep. I mean, they just barely are able to communicate with you. This is a patient that would not be released from PACU into Medsurge. Okay, good job, guys. Okay, great job, guys. Okay, so you have a patient that's experiencing an opioid overdose. Okay, potentially we're going to use Narcan. Okay, that's another discussion. You do everything except for something. Okay, so, yeah, if they're still able to follow directions, we want to encourage deep breathing. We want to keep that O2 saturation up. Yeah, we want to assess the respiratory rate. We want to maintain airway clearance. Remember that anytime you have an overdose, especially of a sedative, we want to make sure that that O2 sat and that breathing rate stays up. We want to assess that respiration. Decrease or cease opioid IV drips. Yeah, if they're overdosing on opioids, we want to stop more opioids from going in them if we can. And okay, so administer analgesics. Okay, hopefully you know that opioids are analgesics. They're painkillers. We do not want to give more analgesics to a patient that is overdosing on analgesics. I made up opioid-induced muscle spasms, so I would certainly hope that they aren't having muscle spasms from the opioids. So great job, guys. This goes back to what we just discussed, kind of. Oh, never mind. This doesn't. This is something else. Ignore me. Okay. So, I got you guys. So let's discuss this. This is something you have to know for the exam. This was brought up on both reviews. If we prescribe both anesthesia and opioids, they both cause severe drops in urine output. Okay, so we're looking at both fluid and electrolyte imbalances in patients that take both. So we have to check both of those. In fact, a lot of patients that are given anesthesia and opioids are also given diuretics to increase the urine output. So blood pressure could be affected by that urine output. And I can see why you'd be like, ooh, orientation and mental acuity. Okay, but I'm going to tell you right now that any patient that is taking anesthesia and opioids, they're going to have a decrease in orientation and mental acuity. That's expected. It's not a priority piece of assessment. But both anesthesia and opioids have severe antidiuretic effects. And so when they're used together, that's compounded. We have to watch to make sure that the patients are voiding at some point. This was covered in both reviews, so I just want to make sure that you guys know that independently you already have to check urine output with these. But when they're used together, it's a priority piece of assessment data that patients are getting adequate urine output. Especially considering that a lot of these medications are outputted in the urine. So if they're not voiding, then they're not necessarily losing that medication. Okay. So moving on, just be aware of that. Urine output if we're mixing anesthesia and opioids. Probably something on the exam, because they both covered it, specifically. Okay, once again, this is kind of just something you have to know. So we treat C. diff with metronidazole. I'm really bad at pronouncing these things. Also known as Flagyl. This was brought up in both review sessions, totally randomly. They're just like, what do you treat C. diff with? Metronidazole/Flagyl. Just know it, especially Flagyl. They specifically brought up Flagyl, like that name, several times. So yeah, C. diff treated with Flagyl. I don't know if that's going to come up or treatment of MRSA, but I feel like at least one of them will be on the exam. And you can't kill C. diff with hand sanitizer. You have to use soap and water.
Duck, do you know where this scale is?
I could not find it.
I have no idea. I have no idea what this means.
I have no idea, but Penelope was like, now you know the PACU discharge score. And I'm like, of course I do. And she's like, well, what score do they need to leave? And I'm like, I don't know. And she said it was either a 9 or 10. And she said that I needed to know that for the exam. So yeah, it turns out that they have to have a score of at least 9 in order to leave the PACU. And this is based on stuff like their current mental state, their respiratory status, their cardiac status. Basically, they do like this fancy calculation, and it gives them a discharge score. And as soon as they reach 9 or 10, they're allowed to leave. I know why you... I don't know where they got this information from, but I'm told that it's on the exam. So a 9 or a 10. I just said greater than 9, if you will. So
Chapter 6
16, and I believe it's figure 16-1.
Okay, it literally just has like the scale there then.
Yeah, yeah, it's on the slides, and then in the voiceover, whatever she said, gave like a figure.
Okay, cool.
But all we need to know is 9 to 10.
Cool. So yeah, I would expect this to probably be on the exam in some sense. They might say provide a scale and then give you an explanation of a patient and you put it on the scale, or they'll just be like, which of these patients, with these scores would be released. That would be too easy, I imagine, but still, 9 or 10 would be the answer.
I don't know if it's just me, but can you zoom out a little bit?
Oh, yeah.
Like, I can see the full answers.
I'm assuming that's not any better, right?
No, I'm not sure what happened.
I'll do something here in a second. Okay, good job, guys. Yeah, so classic C. diff is going to be profound diarrhea that is liquid in nature. Really fast. I have a big monitor. I'm going to make it 1080p, which should help you guys. There we go. Okay, can you guys see this better? Is that any better?
Yeah, that works, thanks.
Okay, cool. All right, moving on. Might actually be too big now. Cool. Good job. For the exam, know your local signs of infection, and then know your systemic signs of infection. Local signs of infection are like imagine an infected wound. Okay, we're talking warmth around the infection site. We're talking the purulent drainage, or the drainage of the bacteria and the white blood cells. We're thinking swelling around the infection site. Okay, so these are going to be all local to the tissue that is infected. Okay, and then systemic signs of infection are going to be across the entire body. So we're talking tachycardia, we're talking hypotension, that's an end stage infection, but still, we're talking fever. So these would be, and like sweating. Those would be signs of systemic signs of infection. So know those for your exam, local versus systemic. There's probably going to be a select all that apply question that says which of the following are local signs of infection. And you'll have to go through, and it'll say things like tachycardia and purulent drainage. And you'll have to be able to tell which things would be right around the wound and which would affect the entire body. So I would expect that on the exam. Good catch, guys. So this is kind of like a trivia piece from earlier chapters, but I do want you guys to be aware of this, and this was brought up during the review session. So specifically what I was told to do was to remember patient education for PCAs. Remember that PCAs are going to be the patient-controlled analgesia, right? So it's basically like an IV pump, but the patient can control when they get the medication by hitting a button. One of the protections built into these is that they only allow so much of a medication to be dispensed over a time period. They do that so that, okay, let's say you have a confused patient, right? Okay, first of all, they shouldn't have a PCA anyway, but okay, whatever. They got a hold of one. they can't just sit there and whack the button repeatedly and overdose themselves. So the PCA is going to prevent that from happening. That being said, it is worth noting that PCAs can interact with other drugs. So, like for example, if they do their PCA, and then you come along and you provide a beta blocker or whatever have you, that drug might interact with the drug that they're taking. In which case, yes, we might see the effects of that. But for the most part, overdoses and PCAs don't really happen, at least from the drug alone. Usually something else has to come in order for an overdose to occur. The other thing that I want you to know, so PCAs don't cause overdoses. That's a good part of education. Okay, another piece of education, not really for the client, but for us, we should know that we don't normally give PCAs to confused patients. Patients need to be fully aware of what a PCA is and how to use it in order to be provided with one. Another big thing, family members do not need to be touching a PCA. Fucking keep the family member on the other side of the room with the PCA. They do not need to be like, oh, he's grimacing, I'm going to click his PCA. They do not touch the PCA, okay? This was like, they had a bunch of practice questions that all revolved around this concept. So I wouldn't be surprised to see it on the exam. You do not let family members control the PCA. I don't care how sweet and loving and how much they care about their person. They don't control the PCA. So be aware of that. So those are probably like the main things I would know about PCAs. You cannot get an overdose because they're timed, or I'm sorry, yeah, they are timed. They control how much of a dosage is released over a time period. They should never be controlled by family members. They should be controlled by the person alone. And that person should be fully alert and oriented. They should have no confusion, and they should fully understand what the PCA does. Also, there was a practice question that was like, ooh, are PCAs, are they okay for patients that are having difficulty sleeping? Okay, they're like, oh, the pain's keeping me awake at night. Is a PCA an effective like treatment for that? The answer would be no, because if the patient has to wake up at night to press the PCA in order to sleep, then they're not sleeping. They're being woken up, which is not an effective treatment. An effective treatment would be an IV drip at that point. That being stated, another thing you should know, there's 2 modes on PCAs. You can do the manual mode, which is where the patient controls when they get pain medication. And then there is also a continuous flow mode, in which case it's basically like an IV drip, or an IV, what is it called? The machine, but where it controls how much they get at a time. So yeah, just be aware that you have either a continuous mode or a manual mode on the PCAs. Cool. That should be everything you need to know about PCAs for the exam. Okay, good job, guys. Really fast to discuss this again. I know there's a lot of confusion between like passive and active and artificial and natural. Remember, active immunity is where you are being exposed to a pathogen and then you are creating your own antibodies against it. Passive immunity is where you are just provided the pre-made antibodies. You never learn how to make them and you don't produce them anymore. So in this case, passive immunity should involve the body being provided with pre-made antibodies, not making its own. Once again, I would expect a question on passive versus active immunity, or natural versus artificial immunity on the exam. So definitely know the difference between passive and active. Remember that in passive immunity, you are not making your own antibodies at any point. You're being given the antibodies by somebody else. Okay, moving on. You guys have come so far just since the beginning of this. These are points that you otherwise would not have gotten. So, ooh, just like that. We do not trust the pain assessments of partially sedated individuals. Great job. Okay, so let's see. So you take her axillary temp. She's out of surgery. She has hypothermia. Okay, so you do the right thing next when you rechecked it rectally, and it confirms that she has hypothermia. The next thing you're going to do is we're going to cover her with what we refer to as a bear hugger. It's basically, for all intents and purposes, it's like a heated blanket. It's just going to help trap body heat inside of her. To help raise her body temperature. These other ones, okay, so warm saline IV drips are used in some situations, but typically speaking, we're gonna go with that bear hugger. This is not an expected finding. You do not want a patient that's hypothermic. And then I'm sorry, I made up the raising the room temperature. I mean, it seems reasonable if you have to, but like still, just be aware of that bear hugger is probably what they're looking for. This seems like the sort of thing that they're probably going to have on the exam, either that you have to confirm it rectally, or that after confirming it rectally, we would use a device to warm up their body. Okay, moving on. Look at you, smart folk. Remember, we're looking at pain goals, not a pain assessment. Okay, so let's discuss, because I can totally see why you'd say A, okay, but I'm going to stop you. So, before a medication administration, you would want to do a pain assessment. You would want to say, you know, where's their pain level now? Then you could compare that to after the medication's administered to see if the pain medication was effective. But pain goals are a different thing, okay? So let's say that's them coming from the Medsurge floor, or coming from a different floor and saying, I have a pain level of 8, okay? Before we even get to the point where we're administering medications, we set our pain goals. So we want to say, okay, you're at an 8 right now. We really want to get you down to a 5, okay? And this is our plan for how we're going to do that. We're going to administer our meds. We're going to reposition you. We're going to do a heat compress. You have to make your plan for how you're going to lower a patient's pain level. That's the pain goals. You would not do that immediately before administering medication. You would do the pain assessment before administering medication. But I could totally understand why you would say that, because I think we're just hardwired to look at pain assessment. But just be aware of the difference between that. So pain goals is going to be like they just entered, whether it be your floor or the hospital. And we're going to see what pain level they're at, and we're going to try to set a goal for how or where we want them to be. Okay, so yeah, just be aware of that. That was part of the review, so I just want you guys to be aware. That's when we're going to set that pain goal. Oh my goodness. I'm very impressed. I really thought that at least a few of you would be like, oh, yeah, it's one of these. Great job. So yeah, know those three. Reservoir. That's going to be where the bacteria hangs out, grows, and lives and reproduces. Mode of transmission. That's going to be the vector, or what method the bacteria uses to reach new hosts. And then the portal of entry is going to be the hole or the orifice that bacteria is going to open or get into in order to infect the body. Okay, good job. Obviously, yes, the size and properties of the bacteria does matter, but it's not part of that list. This is from the last exam. So, VTE prophylaxis. I don't know if it's prevention or treatment. I just know it's VTE prophylaxis and it's a list. I'm sorry. Ooh, I got you with the elastic stockings. Okay, so I know what you're thinking. That was one of the, I think, the 3 or the 4 E's of the deep vein thrombosis one on the last exam. Elastic stockings is not part of VTE prophylaxis. You're thinking of sequential compression, which is kind of similar but not quite. Yeah, so it's heparin or Lobenox administration, early ambulation, and sequential compression. Those are the 3 parts of VTE prophylaxis prevention or treatment. I don't know if it's prevention or treatment, but it's one of them. Elastic stockings, that 3 E's of deep vein thrombosis from the last exam. So I'm sorry, I got you guys. I knew you'd see the elastic stockings, and you'd be like, oh yeah, that was a stupid answer on the last exam. It was the elastic stockings. No, it's not. So if you see on the exam, early ambulation, sequential compression, heparin or Lobenox. Just saying.
Okay,
Oh,
I got a question.
go ahead.
This might be a dumb question.
No, it's not.
VTE prophylaxis, doesn't that mean it is preventing DVTs?
I'll be real with you. I have no idea. I just know the list.
It is. VTE is blood clots, so that would be DVTs in the legs.
And prophylaxis is beforehand.
So, homegirl is a little confused about this question.
See, and I don't fully understand why we wouldn't use elastic stockings as well, but I'm just going off the exact list that we were told to know for VTE.
So, is this... I haven't done a lot of studying because I am done, but is this in a, like, PowerPoint?
Yeah, it's from the last exam. Do you have, like, the 3 E's of deep vein
Yeah, and
thrombosis?
I thought elastic stockings was part of the 3 E's.
This is not deep vein thrombosis. This is something different. There's 2 lists. One is the 3 E's. This is not the 3 E's.
Do you see how I'm confused?
No, I totally see why you're confused. There was 2
This is
different
so
lists that we had
stupid.
to know.
I just need to vocalize that.
No,
I'm sitting here like,
dude,
what the
Are
fuck?
elastic stockings not kind of like this? Wouldn't that be sequential compression?
No, I know what you're thinking. Okay, so sequential compression, we have a device that does it, or we can do it. What that is that's where you like put essentially, if it's the device, it's a machine you put on them that squeezes their leg in specific ways, okay? Or we can technically do it. I don't know why we do it, because it sounds a lot like massaging to me, which is a risk thing. I don't fully understand why we do it, but that's sequential compression. It's where it squeezes it. Elastic stockings is, it's just like a really tight stocking. There is a difference between the two, so be aware of that.
So what is the components of VTE prophylaxis?
heparin or Lobinox administration.
Okay.
Early ambulation.
Okay.
Sequential compression. Those are the 3.
Okay.
Did Penny say this was going to be on this exam too, or are we just like reviewing it?
No. Both reviews, they mentioned to know the parts of VTE prophylaxis. And they went over these 3.
Bro, oh my gosh. I'm done. Oh my gosh.
Okay, but after discussing it, you're probably going to remember this when you get to the exam. Okay, so just...
Yeah, probably.
You know. Hopefully it's not like a select all that apply, but just know heparin or Lobinox, early ambulation, sequential compression.
In the lecture, I just watched it too. It said Ted Hose.
Okay, well I give up. I don't know because Ted Hose would be elastic stockings.
Elastic stockings and Ted Hose are the same thing.
Okay, well, God bless.
God bless.
I have no idea.
We beat the teacher.
If it helps, I just think of it because I remember this from the last one that like VTE, just think of like that's like the first step to a deep vein thrombosis is how I think of it in my head. I don't know. And so you're going to use the sequential compression so that it moves your blood. Like you don't want to move it once you have a clot. I don't know if that makes sense, but in my head it does.
That does make sense. The thrombosis isn't already there. So yeah, that makes sense.
Here's a really dumb question to be asking this far in the semester, but what is the difference between a DVT and a VTE anyways?
VTE, like,
I don't know.
VTE includes DVT and PE, I'm pretty sure.
VTE is any blood clot, so like VTE prophylaxis, like you're preventing any blood clot whatsoever. DVT is like just in your legs. That makes sense?
I thought DVT was in your legs.
Yeah, DVT is in your legs. VTE is any blood clot whatsoever, so it can prevent DVT.
Okay. Cool. Thank you.
Because it also prevents PEs too.
I love this for us.
DVT is a spicy VTE. That's funny.
Yeah, totally.
Duck, come back.
Baby, come back.
Please come back. I won't be able to pass this exam without you.
Okay. Okay. We all are very familiar with VTE prophylaxis now. We're best friends with this concept. Know it, because it was on both reviews. Heparin and Lobinox, early ambulation, sequential compression. I don't know if you need to know the Ted Hose, but I would hope not, because it wasn't on the last exam. And this won't come up again in this Kahoot. So just know you need to know the VTE prophylaxis parts according to our lectures. Moving on. Think about the signs of shock. That's really what we're looking for cardiac status. Oh, you glorious people. Okay, so yes, you could argue that an increased blood pressure would be very bad, but we're looking for signs of we're looking for signs of shock. So we're looking at decreased blood pressure and increased heart rate, because either of those would consider potential shock. Yeah, we don't want them to have hypertension, okay? But as the PACU unit, we're not the ones that worry about hypertension. The people in the Medsurge floor can worry about the hypertension. We're just trying to make sure that they survive anesthesia. We're trying to make sure they don't go into shock after surgery. So hypertension is not really our concern, unless they're in hypertensive crisis, okay? But I would have mentioned if they were in hypertensive crisis. So decreased blood pressure, increased heart rate. If they have those two things, we're talking about shock, okay? And that would be a worrying result in a PACU. All right, let's move along. I know this one's dumb. I'm sorry.
I'm voting D.
I forgot I put that
Biohazard bag. That's almost as funny as your Jose.
I know, yeah, dude, I was so tired. I was like, I didn't realize that I'd spelled it wrong until I posted it. I was like, oh my god, I look like such a fucking dumbass.
I was crying at it. So funny. Typing it out makes me laugh.
Fucking Jose.
It makes me feel better. We all thought that you did it on purpose.
Oh, that's even better.
So we're like, oh, it's so funny. And then you're like, no. I was like,
I
oh.
should have just been quiet then. Oh, that's even worse. Shit. Okay, I know it's dumb. They're on contact precautions. You put a sheet over them, okay? That's what I'm told in the review session. You put a sheet over them. It sounds like I'm dressing them up like a ghost, okay? But no, you put a sheet over them. Just know it. Contact precautions. You put a sheet over them. Droplet precautions. You put a mask on them. Airborne precautions. You still put a mask on them. You're not giving them an N95. These are the ones you need to know, okay? That they might, the exam might say something else. They'll be like, oh, you put I don't know what the fuck they would say, a pad, what else you would put on them, but you put something on them, apparently. It just sounds so dumb. Go ahead.
Yeah, I think for what they mean is like you just put over like their limbs, like so that way like if they have like any like open wounds or anything, they just put like a sheet all the way over like their face.
No, that's what inspired the biohazard. I was just like imagining like the stretcher. You just put the sheet just directly over, like just stay in this bubble. But
you could have it so that the patient is laying like. Yeah, the patient laying flat down, and when you're passing by other people, they can just kind of like move slightly and scare the crap out of everyone.
Oh shit!
No, because when I saw them, I was like, that's what they do when they're dead, and not like when they're on contact.
Yeah, just like a corpse is being wheeled down the hall.
Wait, is it just droplets? They wear the mask.
Yeah, so droplet and airborne, they're gonna wear the mask. Contact, they're gonna be covered. Okay, it might not be a sheet. I don't know, but it's a sheet according to the review session with Penelope. It's a sheet. No mask. They don't need a mask because they're not breathing out the pathogen if it's a contact. So yeah, sweet. Let's move on. Okay, let's discuss, because one of you fellows got it wrong. C. diff, okay? It is, hand sanitizer is ineffective against it. It is the 0.01, that bastard that survives hand sanitizer. You have to use soap and water. And if you are working at a hospital right now and you get a patient with C. diff, you need to know this, because you will go give C. diff to yourself and to your patient if you just walk out and get hand sanitizer, okay? You have to wash your hands. And remember, the classic sign of C. diff is watery, what was the profound watery stool. Okay, unless you and your patients want profound watery stool, please use soap and water. Okay, great job. I'm going to give you a hint because I know some people are still struggling with this. Passive. That means you're not creating the antibody, somebody's giving it to you. Okay, go. Now we're talking. I just had to spoon feed a little bit and things went better. Okay, passive. So you are not the one making it. Somebody is giving you that antibody. And it's temporary because you're not the one producing it. Okay? So, natural. Okay, so we're receiving it either from your own, okay, not from your own, but from somebody else's immune system. So in this case, we've got the mother. Okay, so antibodies are in the breast milk being transferred to the child. Okay, why would that happen? What's the benefit? Well, by doing that, because the child's immune system hasn't grown enough, the mother can pass on antibodies to the child until the immune system has grown to help protect it from different pathogens. So it helps to improve the mortality rate of children. But remember that it's temporary. So that child isn't going to learn those antibodies from the mother. It's just like a temporary protection while it's young in order to give it time for its immune system to develop. Great job, guys. Okay, so let's discuss. So, when do we use each one? So the faces scale. Okay, we got the, you guys know what the faces look like. It's like on the left side, you've got like a normal guy, and on the right side, you've got like a frowny face that's crying. This is the scale you use for children. And the best thing about this scale is you don't really have to communicate much with them. Now, I can understand why you might say the nonverbal indicators, because you're like, how do you ask him about his pain levels if he doesn't know English? Okay, I got you. Yeah, see, you're like me when you're answering these nursing questions. You're like, well, technically, blah, blah, blah. No, okay, he's a 4-year-old. The big thing you need to pay attention to is his age. If he was a very well-developed 4-year-old, I still would want to give him the faces scale. I can see the mental gymnastic you jumped through to say the nonverbal, and it's because he doesn't speak much English. I love you to death. I'm the same way, but you've got to look at the age. It's probably going to be this way on the exam. Anytime you use the faces scale, it's with children that are old enough to understand the faces scale. Once they become more developed, we're talking like I think it's like around like the age of like 10, or I think it's like 8 to 10 or something. That's when you begin using 1 to 10, the scale, because at that point they can understand that 1 means next to no pain and 10 means a lot of pain, and they can put it in good perspective. If you ask a 4-year-old to scale it, if they're able to pull it off, they're probably just gonna be like, it's a 10, when they stub their toe or whatever. So it's just not an effective method. If you see a young child, go with the faces scale. Now, I can tell you right now that based off the reviews, I think what they're going to do is they're going to have a question that's going to say, you have X patient, and then you're going to have a picture that has 1 of each scale. So it'll have 1 with the faces scale, it'll have 1 with the 1 to 10, it'll have 1 with the nonverbal indicators, and then I don't know what the fuck the 4th would be, if there is one. But it's going to say, which of these scales would you use? And then you'll have to select the one. So just know what they look like, okay? But you should be able to infer, if you don't know what the nonverbal one looks like, which one it is, because it's like, it's going to say on it a bunch of nonverbal indicators. So yeah, but just know your pain scales and when you would normally use it. So faces for children, 1 to 10 with most competent individuals, and nonverbal indicators are going to be used for non-competent individuals typically. But great job, guys. Gotcha. So they went over this in both lecture and in the reviews. Need you to be aware of this. Do not, when you have an older patient that is in pain, just be like, I'm going to turn on the TV for you. That'll help. Older individuals are less likely to receive pain medication because they're seen as complaining too much. And it also causes them to report pain less, okay? If an individual says, if an older individual is like, I'm in a lot of pain and the pain medication isn't working, at no point should you be like, oh, well, just watch some TV, okay? Because that's just going to make them feel insulted. This was specifically a practice question in the... fuck, I don't even remember where it was, but I know that we definitely cannot use the TV as a distraction for older pain. In fact, we're supposed to, with older patients, reduce noise levels as much as possible. So that would mean turning off the TV or reducing the volume on the TV, because loud volumes or high activity levels around them can make their chronic pain worse, okay? So, and this is something that's probably going to be on the exam, so I just need you to be aware that if you have an older adult, we are not going to solve their chronic pain by distracting them with a TV. If anything, we're going to try to reduce we're going to try to reduce this volume. We're going to try to turn off the TV. If you see this again, I need you to keep this in mind, and this may very well save you a point on the exam.
Is there anything that is considered like an effective distraction, or are distractions just like off the table?
They're pretty much off the table. There's very rare times that you would be able to do a distraction, and it's basically like as a last alternative, or with young children, okay? Because like young children can be distracted effectively, but with adults, it's often taken as like an insult, especially if there's other things that you can do. So like, okay, they can't sleep at night. We could give them a back massage or a heat compress or something, because if they have back pain. If they're like, I can't sleep because I'm in pain, at no point would a distraction be a viable option for that, for an example. So they would take it as an insult if you said like, oh, I'll just put on some music or to help you sleep or something. So if you see distraction, for like 95% of cases, it's a no. Okay, so try to keep that in mind for the exam. Especially if you see a TV. If you see a TV, I want it to spike in your brain and be like, no TV for older adults for pain. Because they brought it up. And I don't want you guys to lose points on that one. Okay. Great job overall. Really fast to discuss this. If you remember from the last exam, remember septic shock. Okay, we're talking about infection of the blood. Some of the symptoms you're going to see there are going to be decreased blood pressure, increased heart rate, increased respiratory rate. Okay, so tachypnea would be expected as a systemic sign of infection. Same with tachycardia, that increased heart rate. Fever should be expected as a systemic sign of infection. Purulent drainage is going to be drainage out of the wound of infected material. So that's going to be a local infection sign. So try to keep that in mind. Remember that systemic signs of infection. Think of the same signs as septic shock. Increased heart rate, increased respiratory rate, decreased blood pressure, and then you're going to have hyperthermia, so increased body temperature. Those are going to be your systemic signs. All right, great job, guys. And, technically, if you get really deep into it, decreased urine output because got one of those shock signs out there. Wonderful. Great job, guys. Active immunity. You detected the pathogen, and you created antibodies against it. Perfect. selected true. Did you do that to spite me? That's not cool. All of these might be true, but one of them does not impact immunity. Ah, you bastards. Okay. Renal and hepatic functioning. Okay, so both your kidneys and your liver are going to filter out things. That includes potentially bacteria. So having reduced renal and hepatic functioning is going to increase your risk of infection because there's going to be more bacteria in the bloodstream. Decreased skin integrity. Okay, so they're more likely to suffer tears and scratches of the skin, which would allow bacteria to enter the skin, and therefore they're at a higher risk of infection. Reduced immune system functioning. Okay, I might have worded it weird or something, but essentially their immune system isn't as effective as it was when they were younger. Their lymphatic system isn't as effective. And in general, their filtration systems are not as effective, and they have slower responses to infection. So all of these, the reduced renal and hepatic, the decreased skin integrity, reduced immune system function, those are the core reasons why older adults would be at higher risk for infection. Gastric motility is reduced in older adults. It just doesn't have anything to do with immunity. So just kind of be aware of that. If I had to guess, you need to know everything except for that. So it might be a select all that apply that's like, which qualities of older adults places them at higher risk for infection? And it would be like reduced renal ability, reduced hepatic ability, decreased skin integrity, reduced immune system function, and then some trash answers, and you would have to select the correct ones. If I had to guess, that's probably what it is. So just kind of think about it, and these are the reasons why.
In case you guys didn't have SI today, Sarah very clearly said that remember that some select all that applies can have every answer correct. So
she did.
I don't know what she was hinting, but she did say that.
Very glad you said that. Yeah.
Oh, why?
I'm guessing only one will be that way though, because I feel like they do that very sparingly.
I agree, but if it's me, I never select all. So she said that very clearly, and I was like, I'll keep that in mind.
Yeah. Too bad we can't go back to change our answers. So won't know till it's too late, but this might be one in which they would do that. So something to keep in mind.
I do want to mention that there is the changes in pH and that kind of stuff that does affect immunity, but not the motility.
That's true. Yeah, the decreased gastric pH would mean that bacteria could survive that otherwise wouldn't in the stomach. This is referring to okay, if they're getting an analgesia, they should just be given morphine, or they should just be given ibuprofen. That would be considered a unimodal approach, where you give one drug or one treatment. Okay, and I might see where you're going with if you said true to this. So we want to be bimodal as much as possible, which means that we want to take two, typically, forms of treatment. So instead of just offering, say, acetaminophen, we would say, okay, we want to give acetaminophen, but we also want to give a heat compress. Or let's say we want to give morphine, sure, but let's also give ibuprofen. Now, there are some exceptions to this. Like, for an example, I can see where if you said true, you might be like, oh, but what about interactions between analgesics? yeah, you wouldn't want to give like morphine and hydromorphone, okay, because they would have the same effect, and it would cause essentially an overdose. But we always, when possible, want to take multiple methods of tackling a problem, because let's say that you give them morphine and ibuprofen, and it's an inflammation-based pain. They can work together in different ways to solve that pain, which can increase the effect of the analgesic properties. So whenever possible, we want to go with a bimodal, a two or more method of treating pain. Okay, so let's discuss. There's narrow spectrum antibiotics and there's broad spectrum antibiotics. Broad spectrum antibiotics target a lot of different bacteria, but they're not necessarily as effective against those bacteria. And then there's narrow spectrum antibiotics, which specifically target specific kinds of bacteria, and they tend to be more effective as well. So what normally happens is a patient comes in with sepsis or really any kind of like severe infection, and we're going to take a culture, right? We're going to get a blood sample or a stool sample, whatever have you. We're going to send that off to the lab. Okay, well, let's say that lab's going to take 3 days to get back to us. Well, we don't want to just be like, LOL, good luck, come back in 3 days, and until then we're not going to treat you. So in the meantime, until that lab returns, we're going to give them a broad spectrum antibiotic. It might not be as effective, but hopefully, because it attacks a large different number of bacteria, hopefully it will target whatever bacteria the infection is caused by. Once we have that culture back, once we know what bacteria has infected them, then we'll change to a narrow spectrum antibiotic that specifically targets that bacteria. So we'll start with one that's really wide ranged but maybe not as effective, and we'll move to one that is really arrowed, very specific to that, tailored to that specific bacteria. Once we know what it is. So yeah, just be aware of that. It's the other way around. So you'll start with that broad spectrum, and then you'll move to that narrow spectrum once you identify the pathogen. Great job. Okay, so if you didn't see this, then I totally understand why you would choose what you did. So be aware of this. Anytime that we're prescribed incentive spirometry, it's normally administered hourly, bi-hourly, or maybe like 4 to 6 times a day. That does not count when they are sleeping, okay? Because imagine if you were given an hourly incentive spirometry prescription, and every hour out of the night, your nurse came in and went, "Hey, I need you to blow in this tube for me." Literally every hour of the night. It's not going to work. Your patient, well, I mean, I'm sure it'll work, but your patient isn't going to be able to sleep, and they're not going to heal properly. So we only do these incentive spirometry prescriptions while the patient is awake, okay? So it basically gets put on hold until they're awake again. This was a part of the review, and she brought it up like 3 different times. So I'm anticipating that this will be an exam question in some way. If they are prescribed intensive spirometry, we do not wake them up for it, okay? Because we don't want to disturb their rest. It's better for them to rest than it is for them to do intensive spirometry every 1 to 2 hours. Okay, good job, guys.
I have a question. I don't know if you'll know the answer to it. But for the incentive spirometry, like, does that count if it's like during the day and they're sleeping? Like, then should we wake them up?
From my understanding, we basically do intensive spirometry whenever they are awake. We are not going to wake them up at any point unless it's like, okay, if you have somebody that's sleeping most of the day, then you could debate it. But for the most part, sleeping is going to be a better treatment for that individual to heal than intensive spirometry is going to be. We're just going to do it whenever it's convenient for the patient, if that makes sense.
Okay, thanks.
Okay. And great job with the Narcan. Oh, I am sleepy. It's been a long day.
Doc, don't forget about this quiz.
I don't want to hear about this. Oh, fuck. A long night ahead of me. At least I don't have the Hesse tomorrow. Okay, y'all that said false, you're just trying to be contraindicative. I'm sorry. You need to know this for the exam. Demerol, you don't use it in anybody that has decreased renal function. Older adults tend to have decreased renal function. So, know this for the exam. She brought it up like 20 times, and then she brought it up more times in the review. Demerol should not be used in patients with decreased renal function. I'm going to repeat it again. Demerol, you should not be using that in patients with decreased renal function. Know this. I'm sure it'll be on the exam because she was just so adamant about us knowing that. Demerol should not be used in patients with decreased renal function, which happens to involve older adults. Sweet. Good job, guys.
Hey, Doug, quick question.
Yes.
When should Demerol not be used?
I have no idea. Well, no, yeah, you shouldn't use it with anybody that has impaired renal or liver function. I think liver as well, or just renal. It might just be renal.
No, I got it, man. Thank you.
I can't believe that after this exam we get to jump right back into it because next week's finals. Dude, my brain needs to rest.
No rest. None. Zip.
No rest for the wicked. Fuck.
You can rest when you're dead.
Indeed. I might be dead after this next week. We'll see.
I'm already dead.
I don't know if you guys looked on Blackboard, but they put a blueprint up of the final, and it's literally 1 through 60, a description of each question.
Wait, what?
No way.
Holy
So
crow.
there's like 1, hypertension, 2, heart failure, like 3, hypertension and urine output, like stuff like that.
What the fuck? Dude, I can Kahoot the shit out of that.
Christmas came early, fellas.
They download it before they take it down.
Wait, what was that? Can you say that again, Kaylee? What did you say?
It's under content at the bottom of the Medsurge Blackboard. It's the final exam blueprint, and it shows a description of every question 1 through 60.
Wow. All right. Thank you.
They can keep doing that. I won't complain.
I obviously don't know if it's going to be in that order because the order is very specific. It's like heart, infection, math, blah, blah, blah. So I don't know if it's going to be in the order that they're listed, but they do show an explanation of every question.
Nah, because I think the order is randomized for each test. But, I mean, I could care less, dude, as long as I had the list.
Wait, is the final exam review tomorrow? Wednesday at 11:45?
I hope not. I'm gonna be dead tomorrow.
That's what it says with the blueprint.
Fuck! Sorry.
Yeah, it's literally like right after the test.
Great.
Is
Do we
anyone,
get to
what's
nap?
gross?
No. Do we get to eat? Absolutely not.
Does anyone know what time our final actually is that they told us?
I think like 3 p.m. or something whack like that.
Oh, great.
What day is it on again?
Next Wednesday.
Yeah, Wednesday.
Ah,
A week.
lovely.
You got 4 weeks for this exam, but joke's on you. You should have been studying for the exam, final exam.
This is like the only actual final we have, though, isn't it?
Yep.
Okay, cool.
Oh yeah, because they just have the group projects that I don't know when are due. Oh, one's due Thursday or Friday. Friday it is. I don't know. I'm compartmentalizing like hell.
I think one's due Thursday and one's due Friday.
Even better.
That is for Mel's class, not Moyer's,
I'm just gonna sleep for a week after this.
for some reason.
No, Moyers is due on Friday. She sent out an email.
Oh, I thought someone said Moyer's was due on the 10th. I was really mad.
We all thought it was. Like, all of us were prepared for it to be the 10th, and then she sent out an email a couple days ago saying it is the 4th.
We're presenting them. Or are we not? Maybe that's the other. That must be the other one.
No, Duck, we're not. Just turning it in.
What is it? Which one are we presenting? There's presentations.
Don't we also need to do like 2 like voices for each other presentation or something like that?
We do 2 voice responses, and then for clinical judgment, which you're thinking of, Duck, we just have to voice over the whole thing. We don't have to actually present it.
Oh, okay, cool. Okay, really fast, let's talk about this. Bacterial reservoir. Okay, so a reservoir is where bacteria grows and lives. Okay, so, I mean, technically, there might be a bacteria that can survive in saline solution, but I wouldn't know about a saline solution surviving bacteria. Coughing and airborne respiratory droplets. These would both be vectors or modes of transmission. They would not live inside of a cough. They would not live inside of an airborne respiratory droplet. They would, in fact, live inside of your lung, okay? And then they would be released by an airborne respiratory droplet or a cough. So in this case, the reservoir where they live, grow, and breed would be the lung. And then the cough and airborne respiratory droplet, these would be the vectors or the modes of transmission.
I might be wrong, but isn't vector the term used specifically for like insects that carry disease?
No, vector just means what it travels on. So it could be blood, it could be respiratory droplet, it could be an insect. But vector literally just means something that it moves on, if that makes sense.
Okay.
Okay. Sweet. Okay, so we've got active. This means that you are creating the antibodies yourself, okay? And it's not temporary. It's more or less permanent. And then natural. This means that there's no like human interference. We aren't injecting anything, and this is just how the world works. Cool. So in this case, the active would be we are being exposed to chickenpox, and we are producing our own antibodies to that virus. So that would be active natural. This down here, antibodies being transferred from a mother to a newborn. This would be passive, because the newborn is not creating the antibodies, it's being provided with them naturally, and thus it's natural immunity. This one right here, snake venom antibodies being injected. Once again, it would be passive immunity, because this person is being given antibodies, they're not making it themselves. And then it would be artificial, because that individual, because those antibodies are made by humans in labs, they're not naturally occurring. Okay, good job, guys. We are so close to being done. We got 5 more. Let's do it. think about kind of like what stuff exposes elderly people to infection. You know it. I know you know it. You know what's worse than an elderly person? An obese elderly person. I'm not discriminatory against elderly people. I'm just saying for infection. Okay, cool. So let's discuss. So a lot of these people have risk factors for infection, but which one has the most? Obesity is a risk factor for infection. I know it might seem weird, but it is. In addition, he's also elderly, okay? So we've got two different risk factors for infection. This one right here, we got a 36-year-old who has chronic skin inflammation, okay? So we have impaired skin integrity, okay? So we have one risk factor for infection. This one right here, a high school student who is routinely malnourished, okay? He's young, he's not really at a risk factor for infection, but he is routinely malnourished, which is a risk factor. So he has one risk factor for infection. Here, an obese, that's one risk factor for infection, and that's it. So we've got our elderly man here who has two risk factors, and everybody else only has one, and so we would consider him to be at the highest risk for infection. I expect there to be an exam question like this. You're going to have several different patients, and it's going to ask you to choose who is at the highest risk of infection. Assume with medication administration, so I'm talking about like analgesics. Who did that? No. Okay. You do it before you give them drugs, and then you check afterward to see if the drug worked. I love you, whoever did it. I'm not judging. Okay, we all been there, but you know this. Whoa, you legendary people. Half of you didn't even know what the SCIP chart was when we came in here, and you guys are throwing down. Okay, so I get why you say 1 to 3. You probably just confused it with 1 to 2. I see why you say 24 hours, because that's antibiotics. So remember, the two things I want you to remember for the SCIP chart, okay? The first one is going to be that we discontinue prophylactic antibiotics within 24 hours. Okay, so if this was prophylactic antibiotics, this one would be correct. Okay, but this is surgical Foley catheters. Okay, those get discontinued within 1 to 2 days of surgery. Okay, 1 to 2 days. This is something that I expect to be on the exam. Okay, so prophylactic antibiotics discontinued within 24 hours. Surgical Foley catheters discontinue within 1 to 2 days of surgery. Okay, so keep that in mind. In fact, I bet you what it is it's going to be like, ooh, this patient has their Foley catheter inserted. It's been 3 days since their procedure. What do you do? And it'll be like, oh, it's time to discontinue that. Technically, you can't do that though. That's the surgeons. They have to order that. But you know, you got this. Let's go for 89. We're 3 more questions. Yeah, you should just ignore them. No. I can see why you'd say A, okay, because maybe you're like, oh, well, they aren't comfortable with the procedure. I'm telling you right now, though, that during the review, they're like, what do you do if your patient has feelings of anxiety before a procedure? You deploy the therapeutic communication techniques. This is probably going to be a question, okay?
They gave me a lot of drugs.
Oh, see, there you go. You just give them the old anti-anxiolytics, or I guess it's just anxiolytics. You just give them the anxiolytics that are prescribed naturally. You don't just give them to them. Yeah, see? But otherwise, yeah, the therapeutic communication techniques. In fact, actually, I think I wrote it down. I think that they said something would be a question. Let me, really fast. Oh, here we go. Oh, never mind. I know I have it. I thought I had it in here. Please stand by. Because I think that they said exactly what it would be. Here we go. Oh. Yeah, so it says, patient has anxiety before procedure. What can you do to help? Positioning. I don't know why that would help anxiety. Family presence. Okay. Privacy. Okay. And warmth or cold. I don't know why they said that, but can you imagine, like, they're just, like, anxious, and you're like, here's an ice pack. Like, fuck if I know. Like, I don't know why you would do that.
I think I don't know her name. The lady that was doing the SI said that it was like if they're really nervous and, like, sweating, you give them, like, a cold compress on the forehead.
Okay. I was like, why would you do that? Okay, that makes sense. Okay. So, yeah, relieving anxiety before procedure. Positioning. Family presence, privacy, warmth or cold. Cool. And then at Penelope's, she said therapeutic communication. So if you can remember positioning, family presence, privacy, and remember that warmth and cold is kind of like a random one that you have to know, I bet this will, if it comes up, you'll probably remember me saying this. You'll be good. But yeah. Hopefully that's not the select all that apply, that is all of them, because that would suck. Okay, so let's discuss. This was brought up in the review, and they mentioned that this would probably be a question. If you have a patient, first, the way that they phrased it is they said, "What is the like indicative sign of C. diff?" Okay, which would be the liquid stools, and then what would you do if they had that sign? So the first thing you should do if you have a patient that has liquid stools is to get a culture. Okay, you cannot assume that it is C. diff. Okay, because it could be as simple as them eating, I don't know, an uncooked piece of meat, and their stomach gets upset. They have liquid stool. So it isn't potentially a sign, like a sure sign of C. diff. So I know why you'd be like, we should wait for the next one. Okay, but if it is C. diff, you need to know as quickly as possible in order to keep it from causing more damage than it could. So, if you have a patient that has liquid stools, the first thing you should do is get that culture, okay? And you're going to get that culture, probably like alert the physician, etc., etc. But you're not going to initiate those contact precautions until it is confirmed to be C. diff. I know that might seem counterintuitive because, like, oh, you want to stop it while you can. But a lot of times that liquid stool isn't caused by C. diff; it's caused by other things. So you don't want to put them on precautions that aren't necessary. That gets
Some facilities do put them on precautions while the lab's getting ordered or tested.
so like, and that seems intuitive. So like, I would think that you would, but like, just in case if it comes up as an option, remember that if you get that liquid stool, the first thing you should do is get on those clean gloves, which you should already be wearing anyway. You're handling stool, and get that culture for analysis. Cool. All right, this is it. Last question. Oh, it's the hardest one. Can't believe it.
Oh my god. It's your funeral.
Okay. Good work, everybody. Everybody did beautifully. I am so proud of y'all. Really fast, actually no, I gotta let you guys see your scores, because isn't that so exciting? How did you fucks get 84? Wow. That's impressive.
That's me, Duck.
Oh.
I am your duckling.
Look at you. You hacking. Oh my goodness. And my sweater got placed. Thank you. Duck sweater. Okay. So, that is basically everything. That's like 80% of the test. There are a few things that aren't on there. Let me touch on those really fast, just to discuss those. Okay, so, I'm just gonna kind of scroll through here really fast. Okay, and you might want like a pen and paper for this if you don't already. 3 things needed for immunity to function. Okay. 3 things needed for immunity to function. This is from today's review session. You need to have a functional inflammatory process. So inflammation needs to be able to work, okay? You need cell-mediated immunity, okay? The good old cell-mediated immunity. The third one, I put a question mark. I don't know if I heard her correctly. Antibody-mediated immunity. Is that correct, if anybody knows?
That's what I have too. I thought it was wrong. I couldn't really hear her, but that's what I have.
Okay, cool. Then I think
It's
that's
like
right.
you need both cell and antibody mediated responses.
Okay, cool. So yeah, inflammation, cell-mediated immunity, antibody-mediated immunity. Those are the 3 things needed for immunity to fully function. That seems like the kind of thing that would be a select all that apply. So just keep that in mind.
Wait, say that one more time for me.
Yeah, of course. So you have 3 things that you need for immunity to function. Inflammation, cell-mediated immunity, and antibody-mediated immunity. Essentially, you need immunity to work along all stages in order for it to be fully functional. Okay, moving on. Just a quick note. I don't know how they're going to bring this up, but every review session has brought it up, so let's just discuss it. It's probably going to be a question. Facilities may audit hand hygiene. What happens in auditing is that they select somebody, whether it be a dietitian, a nurse, a physician, and that individual is kind of like a secret shopper. They go around the floor, and you would never know that they're watching you, but they're watching to make sure that people are performing hand hygiene, and then they perform a report. So those are hand hygiene audits. Okay, they brought that up several times in the reviews, so I feel like that might be a question. Okay, so hand hygiene audits. Blood cultures. Okay, remember that we take blood cultures before we administer antibiotics. I know we mentioned that in the Kahoot, but I just want to get that again. Blood cultures are taken before antibiotics. That's probably going to be a question. Okay, let's see. Oh, here's one that I didn't get to put on here that will be on tomorrow's Kahoot. Okay, so if you are listening to a physician providing details about a procedure to a patient, right? Okay, so he's explaining, oh yeah, we're gonna take this catheter and shove it in your groin, and it's gonna go to your heart, etc. He explains the whole procedure. Patient doesn't sign the consent yet, right? Physician walks out of the room and you enter, okay? Consent is still not signed. Okay, if the patient does not understand the procedure, you are not supposed to be like, oh, let me explain it to you. You're supposed to call that physician back in to explain any other details. Okay, so just to reiterate that, if you're listening to a physician and a physician explain a procedure to a patient, and that physician leaves the room and you go in there and the patient asks you questions, you need to bring that physician in. You need to bring that physician in to answer those questions. That's part of like the informed consent, is that information should come from the physician. There are some exceptions. Technically, if you're in the room with them, then you can clarify details, but you should have the physician do it just to be safe on the informed consent. Cool. So that's probably a question. So I'm telling you that right now. Call the physician back if questions persist.
Quick question. Did they, in any of your reviews, mention anything specific about timeouts, or do we just need to know what they are?
Okay, so they keep going, know the parts of the timeouts. Okay, let's discuss timeouts real fast. I don't have the list here. I'm going to be putting it on tomorrow's Kahoot. But let's discuss what a timeout is. So a timeout is a period before a procedure where everybody discusses what's going to happen. Okay, so it's used to prevent medical errors. So, like, for an example, we've all heard of, like, terrible things where, like, oh, we've removed the wrong knee, okay? The reason that this didn't happen is because there wasn't good communication. So what will happen is, okay, this person's going in for knee surgery. So before the surgery, they have a timeout. It's a period where everybody gets quiet, and the doctor goes, I am going to perform a surgery on the right knee. This is the right knee that I will be performing on. The procedure I'm going to do is blah, blah, blah. Great. And then the nurse goes, you are going to be performing a procedure on the right knee. This is the right knee. And by doing that, they all confirm with each other what's going to happen. And that is the timeout, okay? It's just like a period of reflection to make sure that everything is correct and that they are going to do the right procedure, just to prevent those medical errors.
Based on in my notes Penny showed, I think part of the timeout is also everyone confirming their name and their date of birth as well.
Yeah, I have that, and then I wrote down too that the timeout is required correct patient, correct procedure, correct site is the three things that need to be confirmed.
Correct patient, procedure, and
correct
site?
Procedure and then site.
Gotcha.
And then if it's regarding like one of your limbs, side. So like having the right side would go with correct site.
I'm writing that down.
And then
that's what I have too. I think that's going to be the question.
Yeah, they said in the video that they showed during lecture that everyone in the room needs to confirm the 2 patient identifiers.
Okay, cool. So I just wanted to discuss that. That was a good thing to bring up. I was going to jump on that. There's a few different lists that we have to know, and most of those were sent out by Penelope. I think she sent out, like, where to find them in the book. But, okay, really fast, let's continue where we were. Malignant hyperthermia. So, first of all, you should know that it's inherited. Okay, so one of the pre-op questions that we're going to ask patients is if they know if they have any family members that have a history of malignant hyperthermia. Okay, there might be a pre-op question that's like, what kind of things are you going to ask patients before a procedure? And then you'd be talking about stuff like allergies. Have you ate in the last 24 hours? Have you taken your medication? Do you have any family history of malignant hyperthermia, etc.? So just be aware that malignant hyperthermia is inherited. If a patient suffers malignant hyperthermia on the operating table, treatment. First of all, we have to assess, make sure that their respiratory system is functioning, that their airway is clear, all that. We have to pack them with ice. Typically the head is the most important part. You want to keep the brain from cooking, essentially. And then the other one, I mean, you have to stop, I think it's like stop the medication. So obviously you're stopping the procedure, but I think there's also like a stop the medication. I think that those are the 3 big ones. Pack with ice, maintain airway clearance, and stop the procedure.
There's a drug. What drug is it? Anybody know on the top of their head?
I don't think it's like a specific drug. I think it's just
Yes,
like...
it is. Yes, it is.
It is?
I think it's anesthesia.
Yeah,
No.
right.
Yeah, it's just stop anesthesia.
Rim something.
There's a reversal drug. I know what you're talking about.
It's dantrolene.
Dantrolene.
Aha.
Gotcha. Dantrolene for malignant hyperthermia. That's it.
She said the absolute first thing you do is stop anesthesia.
Okay, cool. So we got that. I'll have a lot of this like actually prepared afterwards. I just wrote out a list of like, oh, you don't have this on the Kahoot. Let's see.
Oh,
What time
also,
are
I
you
don't know if
doing
anyone...
the Kahoot tomorrow?
What's up?
Go ahead.
I don't know if anyone saw the Blackboard post that Penny put out like an hour ago, but she gave us all the information we need to know about PCAs, and she gave us an example math problem using a PCA. So I'm assuming that's like word for word how it's going to be phrased as a math problem on the exam, if we want to look at that.
Let's see.
It's an announcement and under the SI.
Here, I'll look at that.
And what time are you doing the Kahoot tomorrow?
Oh,
with
never
us?
mind. I'm not in the SI, so I actually just have to chill in here. But that's good to know. Okay, so they said to know the surgical checklist for pre-op. Okay, so there's a few pieces of information we have to know. I don't see how much of this could be, unless it's a select all apply, I don't know how much they could do. But so it's pre-op, before they go into surgery. You have to check their name and date of birth. You have to check that their name and date of birth like band is on. You have to check if there has to be a timeout for that procedure. A timeout has to be done pre-op. You have to check allergies and an allergy band. You have to get consent form if applicable. You have to mark the site if applicable. You have to make sure that the patient voided, and clothing and valuables removed if applicable. So name and date of birth, name band, timeout if applicable, allergies and allergy band, consent, mark the site if applicable, patient voided, then clothing and valuables removed. I know it's a lot, but that's the surgical checklist for pre-op. Mentioned that pre-op patients should bathe at home, or like they should bathe before the procedure, but they should not shave because shaving provides a method for bacteria to enter for infection. Okay, this was on all of the review sessions, so know this. Pre-op teaching helps with post-op adherence. If you tell them why you're going to be doing stuff after the fact, they're more likely to do it. So, like, for example, if you're like, okay, they're going to get knee surgery, and before they go in, you're like, okay, but after you're out, we're going to make you walk around. And it's going to be really dumb, but it's going to help you heal. Then they're going to go in, and they're going to be like, oh, I'm going to walk around when we're done. If you don't do that, then they might get their knee surgery, come out, and then you're like, oh, okay, time to walk around. And they're like, why are you making me walk around? Like, I just got surgery. If you explain these things to them before the surgery, they'll be more likely to comply with you afterward. So know that pre-op teaching improves post-op adherence. Okay. Like we mentioned before, SATA, one of them is likely to be all correct. Okay. NPO. NPO pre-op. Why is it so important that patients don't eat before a procedure? Somebody answer that.
They can aspirate.
Aspiration. So, okay, they're getting their surgery, and while they're unconscious, they vomit up that meal that they consumed, and now that blocks their airway and they die. They aspirate and die. So we try to reduce the likelihood of that by making it so they don't eat before a procedure.
So if there was a question like, you're doing a pre-op checklist with this patient and they stated that they ate breakfast, what do you do? What do you anticipate like a correct answer being?
You would alert the physician, definitely.
Okay.
Because more than likely it will be delayed, but if one of the answers is delay the procedure, that's not up to you. You have to alert the physician and they have to delay the procedure.
Okay, because I was trying to think of like what the answer to that would be, because that seems like a very them question.
basically, if you get anything like that, it's like, oh, they haven't voided in 24 hours, or like, oh, their potassium is high, or whatever. If it's pre-op and something's off before the procedure, tell the physician.
Okay.
That's going to be the rule of thumb for this exam. Okay, so we've
Also, something that I just remembered from the review is about like the select all that apply, which I thought was very weird to mention. She said that you might have like a question where all the answers are right.
Yeah.
I feel like we're gonna have a question where a select all that apply where all the answers are right. So I just want people to be aware for that because I know that sometimes those trick me up because I'm like they can't all be right. But
God truly is dead.
Let's see. Last analgesic. Most of the stuff we already went over in the Kahoot. I'm just looking through. She said to know if IV medication is not compatible with an infusion. So if they're already getting infused something and you get given something to push, then you should stop the drip from whatever they're getting that's incompatible. You should flush the line, and then you should administer your medication, and then flush the line again and reconnect the drip. So it's saline, or like disconnect, saline, administer, saline, and then reconnect, essentially. I don't know why she brought that up, but it seems strange that she did, frankly. So just be aware of that. Oh, yeah. You know my questions where I said unimodal and bimodal? The reason that I brought that up, so Penelope went over it as bimodal. On the second review session, she said that we use bimodal and multimodal for the treatment of breakthrough pain. So if you see anything about breakthrough pain, it's probably that bimodal or multimodal pain approach. So we're going to give them several different kinds of pain medication to help prevent breakthrough pain. Know that older adults respond differently to pain meds. They're slower because of kidney and liver changes. They need smaller doses. Medications last longer. And they have an increased risk of both adverse effects and overdose because it doesn't get filtered out of their body the same way. This is one that was brought up in both reviews. Older adults are at risk for undermanagement of pain. The reason why is because they often feel that they are like a burden, and they try to hide it. I don't know how that's going to be incorporated into a question, but they both brought it up really randomly. So just know that older individuals are at risk for undermanagement of pain because they don't want to like express that they're in pain. Let's see. Oh, this one's, you probably wouldn't know this unless you went to the review. Drainage. Okay, so you have a patient that has a incision and it has drainage, or maybe it's an infected wound. I don't know. You're wondering if it has increased drainage. How would you assess it to make sure that there is not more drainage? Okay, so I didn't know this before, but maybe I'm just clueless. But so what I was told in both review sessions, well, in the second one she didn't mention how to do it, but Penelope did, is that you draw where the wet spot is on the bandage. Okay, so you see like blood soaked through the bandage or whatever. You draw around the bandage. You draw around the drainage. And then when you come back to reassess it, you look at your drawing. And if the drainage has gone past that drawing, then you know that it has drained more. See, that seems weird to me because I'm like, why are you reusing the bandage? Like, get another bandage. But apparently they do that. So drawing on the bandage is an effective way to monitor how much drainage has changed.
I think the reason you don't just like take it off and place a new one, I feel like I remember her saying this in lecture, is that you don't remove a surgical dressing without the doctor doing it.
Yeah, especially if it's like a sterile dressing. I didn't think about that. If it was like a cardiac incision or something, I mean, there's no way that you could just be like, oh yeah, I'm just gonna use aseptic procedure on that. We got that. Okay, so post-op assessment. You notice that your patient is restless. What might that be if they're restless? Anybody?
Pain.
A second big one. Respiratory distress. Yeah, so if you have a patient that's post-op that is restless, you're going to look for respiratory distress and pain. Cool. Got that. I think that's about it. Yeah. So I'm getting up like super early in the morning, like 4 a.m. And I'm gonna be making basically another mini Kahoot. It's gonna be about 30 or so questions, and I'm gonna be doing that at 7. You guys are welcome to join me then, or you can drop in at 8, and we'll go over the rest. But all right, guys, I think that'll be it. So yeah, thank you guys so much for coming. Best of luck on the exam. Might see you tomorrow, but yeah, I'll see you around. Yep, I'm done. You're good. Sorry, Annie.
You're good. I was about to come down here with Milky, and then I realized I heard you closing, and I was like, okay.
Sorry, Annie.
It's fine. No, they've all been harassing me. I thought they just wanted to be near me.
I gotta do a quick assignment, and then I'm heading to bed.
An assignment?
Yep. Hey,
Quick it is.
could you bring me 2 Luna?
Yeah.
Be put down.
We need to get more of that, by the way.
Never mind, 1 Luna. Because I don't know run out.
Have you been taking it like that?
Yeah.
I take it too. I took it last night. So yeah, couldn't sleep. I took it for a few days in a row. One night. I think maybe that.
Yeah, I just use it to put me down.
I do too. Even if I'm already kind of sleepy, I'm like, oh yeah. Except for a while there, I was having issues waking up in the middle of the night because I was having nightmares and shit. Hello? Yeah, but when I take it, I take 2. Because I don't fuck around, so. That's probably why we ran out a little bit earlier.
I feel.
How do you feel? Wow. Oh, yes. I'll have to show you these pictures that I got of Thomas. I was sitting upstairs and coloring and watching TikTok because I usually watch TikTok on Sundays or usually studying and stuff. So I'll take a few hours, 2 or 3, and watch TikToks. But I was making up for Sunday. So I didn't do it on Sunday. But anyways, I was upstairs coloring and watching TikToks. And I don't know, I just needed to look behind me for whatever reason. And I had no idea that Thomas was laying there. But he was sunken in between the pillow and the wall. And his face was all smooshed, so just one eye was
No.
I got a picture of it.
Little Dean.
Look at him. He kind of perked up a little bit when he saw my phone. So I didn't get him in this full position. But look at that. He's so cute.
Little Dean.
Yeah, that shit cracked me up. And you're taking Luna?
Yep.